Okay, so let's begin this next module on peripheral and cerebrovascular disorders. So when we say peripheral, we're typically talking about the legs. Okay, so peripheral arterial diseases of the legs or peripheral venous diseases of the legs. We would also include the arms. It's less common to have arterial occlusions or blockages in the arm compared to the legs, but it can happen. Okay, so peripheral arterial disease, and we're going to talk about peripheral venous diseases, and they're different. Okay, and as well, we're going to talk about cerebrovascular diseases, which is basically another term for transient ischemic attacks, different types of strokes. Okay, and we'll talk about those. And as well, we're going to cover topics related to hypertension. Okay, let's move on here. Okay, so this is really just a review. You can see that the vascular system, and when I say the vascular system, I'm talking about all of the arteries, all of the capillaries in the body, all of the veins. It's a closed system. Okay, so blood is pumped from the left ventricle into the aorta, and it spreads out to all the different arterial beds. So whether it's in the brain, in the lung, and in the lungs, in the legs, all over the body to bring nutrients to the different parts of the body. Okay, and then of course, once these organs have received arterial blood flow, um, exchange of nutrients, oxygen, CO2 occurs at the capillary level, and then they become tiny veins. We'll call them venules, and they collect into larger veins, which then drain back into the inferior and superior vena cava to make their way back to the right atrium. Okay, so really think of the vascular system as a closed system. Okay, and really the amount of blood flow that is required depends on many factors, right? So if someone's exerting themselves and consuming glucose and oxygen, well, cardiac output is going to increase to meet that demand, right? If someone is sick, has a fever, well, cardiac output is going to try and increase because there's increased metabolic demands for oxygen and glucose. Okay, so really the key is that the heart wants to maintain adequate perfusion to all the different capillary beds in the body. Okay, the body does not want any organ to become ischemic, meaning low blood flow to that organ. Okay. Okay, so let's look at some different areas around the body um, where the arteries typically become occluded. And there's many risk factors for arterial vascular disease leading to occlusion, right? And by far the most common cause of arterial occlusion is atherosclerosis. So if you recall all the risk factors for atherosclerosis, well, you can get occlusion in many different parts of the body due to atherosclerosis, and we just will call these diseases by different names depending on which organ is affected. So let's look at the cardiovascular system. Okay, so if you have occlusion of your coronary arteries, where now the blood flow is impeded due to blockage in some of the coronary arteries, when you exert yourself, you aren't getting enough blood flow, and you get angina, right? If there's a complete occlusion of a coronary artery, then you can develop a myocardial infarction. Okay, An aneurysm we'll talk a bit about later, but an aneurysm is basically just a dilation of an artery, right? So if we talk about an aneurysm of the aorta, it's a dilatation or a dilation of the aorta that gradually gets bigger and bigger and bigger. And what's the risk factor, or what's the risk of what's going to occur in the future is hemorrhage, right? The aneurysm is going to rupture, and there's going to be a massive hemorrhage. Okay, and we'll talk about those. Intermittent claudication is what happens in the legs, right? So we have a large artery that goes down each leg called the femoral artery, starts in the groin. And the femoral artery can become occluded with atherosclerosis. And if it's a partial occlusion, you don't typically have any pain at rest. There's enough oxygen getting through in terms of blood flow to feed and meet the metabolic demands of the leg. When you exert yourself and you have a partial blockage, then you get leg pain, right? There's not enough blood flow when you exert yourself because the muscles need more oxygen and they need more glucose, so they become ischemic. And that's called intermittent claudication. So if someone has intermittent claudication, it's when they're walking or running that they start to get leg pain. And when they stop, the leg pain resolves, okay? Because the leg doesn't need as much oxygenation and nutrients, okay? What else can happen with the cardiovascular system? So let's keep on the theme of the legs. So if we check someone who has occlusions of the arteries of their legs, well, when we check their pulses at their ankle, there's two pulses that we check, the dorsalis pedis and the posterior tibial artery. Well, those pulses will typically be diminished or absent, okay? Because if there's a blockage in the upper part of the leg artery, we're not going to feel good pulses at the ankle, okay? If there's unequal peripheral pulses, say the left leg doesn't really have a good pulse at the ankle, but the right leg does, well, that's an indication that there's peripheral arterial disease of the left leg, right? There's a blockage in the artery that's causing diminished peripheral pulses. Capillary refill, you can test this on yourself. Just press your fingernail down and see how quickly the blood returns to the fingernail once you've released your finger. It's usually within 2 seconds. So if we have poor capillary refill in our legs, say if I was to press someone's toenail down and release it, and I could see that it took a long time for the blood to return to the toe, that's an indication that there's not good blood flow to that leg or to that foot, okay? So that's cardiovascular system. The neurologic system, so if you have, say, atherosclerosis in arteries going to different parts of your brain, well, you can develop TIAs, where little bits of atherosclerosis break off and travel to a part of the brain and give you transient symptoms, right? So someone comes in and they say that they had 10 minutes of inability to speak, and they had slurred speech, and they had a droopy face for 10 minutes, and then it resolved. That's a TIA, okay? And that's usually from a little bit of atherosclerotic plaque that broke off and traveled to that artery. A stroke is permanent neurological injury. A TIA is transient, okay? Remember, TIAs are risk factors for strokes, right? If you're getting TIAs, it's an indication that you have significant atherosclerosis and you're at risk for developing a stroke, okay? So an ischemic stroke is where the artery feeding a certain part of the brain has completely occluded and the brain, that brain tissue dies permanently, right? So, and now if we're looking at the neurologic system, remember, you can have a stroke to your eye, right? So if the artery to the eye becomes occluded with atherosclerosis and it clots up, you have the sudden onset of blindness, right? So remember that you can lose vision from a stroke. What else are we looking at? So the skin. So let's go back to the leg and think of this partially occluded artery in the leg. So what's the leg going to be like? Well, the leg's going to be on the cold side because it's getting less blood. It's going to look a bit pale, again, because it's getting less blood. The skin and the nails aren't getting their regular blood supply, so they're going to atrophy. So the skin will look thin, it won't heal well, it's at risk for ulcers. There's usually hair loss on the leg with an arterial blockage because the hair follicles can't grow properly due to lack of oxygen. And finally, if the blood flow is really diminished, the ulcers can become gangrenous, meaning they become infected. Okay, so I really think of low blood supply anywhere is diminishing the oxygen. And when you diminish oxygen, say to your leg, just ask yourself, what's going to happen when I get less blood to a leg? It's going to be cold. It's going to be pulseless. It's going to be pale. It's going to be, I mentioned pulseless. I was going to say the dorsalis pedis and posterior tibial pulses are absent. The skin is going to look thin and shiny. There's going to be an absence of hair. They're going to be prone to ulcerations. Okay. Now, remember, you can have blockages of arteries to any organ. So the next one, the genitourinary system, well, the artery that's feeding the kidney, the renal artery, that can become occluded. And if you have renal vascular disease, so say you have atherosclerosis to your renal artery, well, what's going to happen? The kidney is slowly going to die, right? And you're going to gradually develop renal failure if it's affecting both kidneys, so both renal arteries. Luckily, it often only affects one kidney, okay? So on top of that, the genitourinary system, if you have atherosclerosis and arterial disease, it can lead to impotence because of damage to the genital organs, right? Why do they get damaged? Lack of blood supply. And you can develop impotence, right? Reduced erections can occur. Musculoskeletal system, so just think of lack of blood supply, like I mentioned in the leg. The muscles are going to atrophy, they're going to get smaller because of lack of oxygen. The skin is going to get thin. The hair is going to start to disappear. Okay, so just try and understand what's going to happen if there's partial occlusion of an artery going to an area, such as a leg, and what happens if there's a full occlusion of an artery. So in the heart, a partial occlusion we'd call angina, and there's varying degrees of angina, right? There's stable angina, and there's unstable angina. If there's a full occlusion, well, now we're looking at a myocardial infarction. In the leg, if there's a partial occlusion, we're looking at intermittent claudication. If there's a full occlusion of the femoral artery, we're looking at an ischemic leg, right? No blood flow to the leg is going to die. It's going to be cold, pale, incredibly painful, paresthesia, meaning numbness, paralysis, the muscles are dying, pulselessness, poikilothermia is the term we use for cold, okay? And it's all due to lack of blood supply. Okay, so let's move on and talk about some peripheral vascular diseases, okay? Again, when we're talking about peripheral, we're typically talking about the legs, but sometimes we're talking about the arms. You can actually develop a deep vein thrombosis of an arm. But what's the most common place to get a DVT? The leg, right? You can get, so that we're talking about the veins there. If we're talking about the arteries, you can get intermittent claudication or an ischemic leg of ischemic limb of the leg, and that's by far the most common, but it can occur in the arm. Okay, it's just very unusual to get a blocked artery to your arm. It is possible, it's just less common than it occurring in a leg. Okay, so when we're talking about vascular diseases of anywhere, just ask yourself, are we talking about an arterial issue or a venous issue? Okay, remember, arteries bring blood and nutrients to organs and limbs and all the tissues of our body. Okay, so if there's an occlusion of an artery, that's going to give specific symptoms and signs because that part of the body is no longer getting proper oxygenation and nutrients. Let's go to the other side, the venous side. So the nutrients got there because the arteries are working, but the venous is what returns the blood to the inferior vena cava and finally the right atrium back to the blood. Okay, so if there's issues with the venous side, it's not an oxygen or necessarily a nutrient problem, but there might be backup of blood and edema and swelling to areas because there's an issue with the venous side. And we'll talk about the differences as we go along, okay? But keep those separate. Those are different disorders. Arterial disorders, they're typically caused by atherosclerosis of the arteries. Venous disorders are not typically caused by atherosclerosis. That's an arterial disease. Okay, venous disorders may be an issue with the valves. It may be an issue with compression of the veins due to obesity. So really try and keep them separate. Otherwise, it'll be confusing when you're just thinking of vascular disorders in general to try and distinguish what the problem is. Okay. Okay, so let's talk about peripheral arterial disease. And I know we have already, but let's look at the image. So in the upper image there, or in the image, it's showing you a normal artery. Okay, so a normal artery is clean. It doesn't have any plaques. It has no damage to the intima, which is that endothelial lining, that inner lining of the artery. It's perfectly clean to allow normal blood flow. Okay, let's look at the lower image, where the artery is now becoming occluded with atherosclerosis or plaque formation. And the lumen of the artery is becoming really, really tiny. So you can imagine how difficult it'll be for blood to flow through that very narrow lumen. Okay, what's the cause of peripheral arterial disease of the leg in particular, and less commonly the arm? Atherosclerosis. And atherosclerosis, remember all of your risk factors for atherosclerosis, right? Damage to the arteries. So it could be smoking, it could be diabetes, hypercholesterolemia, hypertension. There's many, many risk factors for that lead to atherosclerosis of arteries all around your body. Okay, so atherosclerosis is typically a widespread disease of many arterial beds, but often someone will develop a symptom of one arterial bed because the artery has become so narrowed in that area that they're symptomatic. Okay, so if we look at the leg here in terms of peripheral arterial disease, what's the overriding issue? Decreased blood flow to the leg. Okay, and that is what's either going to cause intermittent claudication, where say someone walks, say 20 or 30 or 40 steps, and they get this cramp in their leg, and it's a painful cramp, and they have to stop walking. And when they stop walking, it goes away after about 30 to 60 seconds. If they start walking again, it begins again. That's intermittent claudication. Okay. If you have a complete occlusion of the artery in your leg, no matter what you do, you are in misery. The leg is dying. Okay, so it becomes an emergency. Intermittent claudication is not an emergency. Ischemic leg, where there's a complete 100% occlusion, is now an emergency. So it's kind of like a heart attack of the leg. Okay? If we don't do anything, the leg will die. So how do we diagnose peripheral arterial disease, whether someone comes in with intermittent claudication or a complete occlusion of an artery? Typically, when someone comes to the hospital, we're going to look at their leg first and see, is it pale? Is it cold? Is it pulseless? Is it really painful? These are all signs that arterial blood supply is diminished to the leg. Okay? We can do what's called an ankle brachial index. So we'll take a blood pressure of the arm and check what their blood pressure is, and then we'll put the blood pressure cuff around their lower leg and do a pressure check of the ankle area. Okay, and usually, so say you get a blood pressure of 140 in your arm, usually the ankle blood pressure in the arteries down there should be around 90% of your arm blood pressure. Okay, so if we do an ankle brachial index, so basically what you do is that equation at the bottom of this slide, the 0.9, you take the blood pressure of the ankle, and that's the numerator. So say it's 130. And then you take the blood pressure of the arm, say it's 140. So it's 130 divided by 140. Well, that's going to be greater than 0.9, no peripheral vascular disease. Say we do a blood pressure of the ankle and it's 80, and the blood pressure of their arm is 140. Well, 80 divided by 140 is about 60%, or 0.6. That's not good. That means a significantly diminished blood pressure that's getting to the lower leg because of an occlusion. Okay, so that's what an ankle brachial index is. Okay, and we use that all the time. So not only checking the pulses, but also doing an ABI, ankle brachial index. What else can we do? Well, we can do an angiogram. So we can inject dye into their arteries, and we can scan the leg either with a CAT scan or an MRI and see if the blood flows properly down the leg. And if it doesn't, it's going to tell us where the clotted occlusion is occurring in the leg, which is then going to allow the vascular surgeon to get to that area and either bypass the area or get rid of the clot in that artery. Okay. Okay, so peripheral arterial disease assessment. Again, peripheral arterial disease, we're thinking of the less severe form is intermittent claudication. No, it's not an emergency. Yes, it's very bothersome to the person because they get leg pain with exertion that they have to stop. So typically, they still need to be investigated. It's just not urgent. That's all. Compared to ischemic leg, which is 100% blockage of the leg, that's urgent. What are risk factors for peripheral arterial disease? Well, they're the same for atherosclerosis anywhere else in the body, right? Hypertension, diabetes, smoking, the list goes on and on. I won't go through all of them, all the cardiovascular risk factors. Okay, but all the risk factors that you know for atherosclerosis of the coronary arteries in the heart, they're going to be the same for arteries of the leg. Okay, so what can we expect to find? This is going to be repetitious, but that's okay. That's okay. That's how we all learn, by repetition. So intermittent claudication. So I mentioned that it's pain due to an inability for the blood flow to keep up with the demands of the tissue. Okay, and that's during exertion. Okay, so the 75-year-old person that comes in and says, listen, every time I walk up this hill, my calf aches, I can't walk anymore, I'm limping, I have to sit down and the pain goes away. That's classic for intermittent claudication. Okay. Now, what else may we find in someone who has chronically low blood flow to the leg, i.e. intermittent claudication? Well, they may be complaining of some numbness or burning to their feet. Why? Well, because there's lack of oxygen to the nerves in the feet, so they're getting some numbness, right? They may have an increased capillary refill time. So I press down on their toenail, I let it go, and it takes 5, 6, 7 seconds for the toe to pink up again. That's a poor capillary refill time, right? Loss of leg hair, I mentioned. What about rubor and pallor? Okay, so what if I have someone lying down and I suspect they have peripheral arterial disease? And they're lying flat, supine, and I lift that leg in the air. If they have peripheral arterial disease, it's going to look even more pale when it's elevated, because now gravity is working on the leg to stop the blood flow to get to the foot. So it's going to look more pale. What about if I put the leg over the end of the stretcher? So I get them to lie close to the side of the stretcher, and I just lie that leg over the stretcher so that it's touching the floor. Well, now gravity is helping the blood flow a bit, and they get what's called dependent rubor. So the leg suddenly really pinks up. Okay, so it might look a bit pale when they're lying there. When you put it in the air, it looks more pale, and when you put it down towards the floor, it looks more red. So dependent rubor. Okay, and the pain. If someone has peripheral arterial disease and they have pain to the leg, the pain is going to be helped if you put it in a dependent position, meaning down towards the floor while they're lying supine, because you're helping the blood flow get down the leg. Okay, so really just think of intermittent claudication as a partial occlusion, only symptomatic with exertion, compared to a complete occlusion, which is an ischemic leg. It's an emergency, and that's where you think of the 6 P's, right? Pulselessness, poikilothermia, meaning cold leg, pale appearing leg, paresthesias, because the nerves are dying, paralysis, because the muscles are dying, and lastly, pain. So someone who's lying on a stretcher with severe pain in their leg, they don't have intermittent claudication. They have an ischemic, completely occluded artery. Okay, so those are the 6 P's of arterial occlusion of a leg. Okay, so some peripheral arterial disease. Remember, we're talking about arteries of the leg here. Intervention. So the first one, so initiate exercise gradually and increase slowly, right? Someone's not going to be able to walk through intermittent claudication. If they continue, it's going to just get more and more and more painful. Okay, so they actually have to rest the leg for the intermittent claudication to go away. Just like stable angina. What does someone do when they have stable angina? They sit down, they rest the heart, they may take a nitro pill under the tongue, and the chest pain goes away. Okay. Promote vasodilation. So a warm environment for sure compared to a cold environment, because that's going to promote vasodilation. We don't typically put direct heat on the leg. That's not going to really change much to the larger arteries that are blocked. And avoiding any vasoconstrictors. So someone who has peripheral arterial disease, we're not going to, we don't want them to be taking pseudoephedrine for their nasal congestion, or phenylephrine as a nasal spray for their nasal congestion. We want to avoid all of vasoconstrictors because it's just going to make their symptoms worse. Okay. Positioning. So avoid crossing the legs. When you cross your leg, you're not only compressing the veins that we'll maybe talk about when we're talking about the venous side, but you can actually compress the arteries as well. Okay? Avoiding restrictive clothing, that makes sense because you're just going to put more potential restriction on arterial flow. Okay? Dangling the legs if you're supine. So if you have intermittent claudication and then you lie down, putting it in the air is definitely going to make the symptoms worse, right? So putting it in a dependent position below the level of the heart is going to improve the symptoms. And patients with intermittent claudication, what do we treat them with? Well, so we're going to investigate it. Typically, we're going to do a Doppler ultrasound of the artery. Okay, so we can actually look at the arteries of a leg with a Doppler ultrasound to look at the flow. And we can also look at the veins with ultrasound to diagnose DVTs, right? So we can look at the arterial and venous side with an ultrasound. So we definitely investigate people with symptoms of peripheral arterial disease, and if we see that there's an occlusion, okay, of the artery by ultrasound, we're also going to check ankle brachial index, which is going to tell us the degree of how blocked the artery is, and we treat intermittent claudication with antiplatelet medications such as aspirin or clopidogrel. On top of that, we give them cholesterol-lowering agents such as the statin group, lovastatin, simvastatin, atorvastatin, any of those that will try and slow down the progression of the atherosclerosis. And of course, the antiplatelets allow for blood to flow through the narrowed lumen of the artery that's occluded and provide more blood supply down the leg. Okay, so let's look at some procedures that can be done for peripheral artery disease. So remember, when we're talking about peripheral artery disease, we're talking about a spectrum of intermittent claudication, so varying degrees of intermittent claudication, all the way up to an ischemic leg, which is fully blocked, and of course that's an emergency. So the first one is transluminal angioplasty. If you recall, angioplasty is used for coronary arteries to open up the coronary arteries in someone who has angina. or a myocardial infarction. It can also be used to open up a artery in the leg, such as the femoral artery. So it's called transluminal angioplasty. So they put a catheter device, they thread it into the artery, they put it through the atherosclerotic plaque, and then they open the balloon. And that basically compresses all the plaque out of the lumen of the artery, and it squashes it against the arterial wall. Okay, so patients need to be on anticoagulants during this procedure so that the vessel doesn't reocclude and get blocked again. Otherwise, this procedure will have a high risk of reocclusion. Okay. Now, you can imagine that during the procedure, when you're blowing up a balloon in someone's artery, there is a risk for rupturing the artery and leading to a hemorrhage. Okay, it's a small risk, but it can occur. Okay, so the anticoagulants are for avoiding restenosis. And of course, the antiplatelets that patients take afterwards are usually lifelong, and they're to prevent platelets from sticking to the site of atherosclerosis, so it doesn't restenose. Okay. Another procedure is called rotational atherectomy. It's basically a device that again gets threaded into the artery, and it's turning like a drill, and it goes into the clotted artery, and it's like a rotor-rooter. It just keeps on turning and breaks up the atherosclerotic plaque and opens up the arterial lumen. Okay, so again, there's a risk of bleeding here if that device were to puncture the arterial wall. Anticoagulants are also needed during this procedure, such as heparin, to prevent reocclusion of the artery during the procedure. And typically, patients will stay on lifelong antiplatelets after a procedure like this for peripheral artery disease. Okay, so the next slide's on an arterial condition as well. Totally different than what we've been talking about in terms of atherosclerosis. This is not caused by that. Raynaud's disease, or Raynaud's syndrome, or Raynaud's phenomenon, is a condition of arterial vasoconstriction. So there's no clot in the blood vessels. It's just that the little arteries of the fingers and sometimes the toes become vasoconstricted, and that reduces blood supply temporarily to the fingers and to the toes. Rarely it can happen on the nose or the ears as well. Okay, so you can see in this image on the left that typically what happens with vasoconstriction is that the fingers turn very pale first because of lack of blood supply, followed as the vessels start to open, the fingers start to look a bit bluish, and then return back to red, normal appearing digits. Okay. So now some people can have Raynaud's disease all by itself and no other underlying condition, and we would call that primary Raynaud's syndrome. Okay. There's conditions that cause secondary Raynaud's phenomenon or syndrome, and we'll talk a bit about those. Okay. Now, typically, if it's secondary Raynaud's, it's often due to connective tissue diseases such as rheumatoid arthritis, scleroderma, or systemic lupus. Okay. Now, on top of those, certain occupations, such as construction workers that have ongoing continued vibration to their hands because of the machines they use, are at risk for developing Raynaud's disease. Smokers, because smoking causes vasoconstriction, can cause Raynaud's disease. And actually, birth control pills can cause secondary Raynaud's disease. Okay? So primary Raynaud's, it's all by itself. There's nothing else causing it. Secondary Raynaud's, is caused by another underlying condition. Okay. So, what are the interventions for this? So, I would say the biggest intervention is making sure that the hands stay warm. And the reason for this is because changes in temperature is a big trigger uh, for for this condition. Okay. On top of that, stress is a big contributing factor. So, for example, if you live in a cold climate, cold hands can trigger vasoconstriction and lead to Raynaud's syndrome. Okay, so cold is a trigger, caffeine intake is a trigger, smoking, as I mentioned before, and emotional stress. Now, that's not to say that everyone who gets cold hands develops Raynaud's syndrome. That's not the case. These are just triggers for someone who's already prone to having the condition. Okay. What treatments can we offer? Well, as I said, the main one is keep the hands and feet warm if you live in a cold climate, because that's going to trigger an event of Raynaud's syndrome. Sometimes we'll use calcium channel blockers like nifedipine or amlodipine. Um, and what they do is they cause vasodilation of the arterioles, which can reduce the number of attacks that someone will get. Okay? So that's what Raynaud's syndrome is. Intermittent arterial vasoconstriction of the vessels of the hands and sometimes the feet. Okay, so let's look at another condition that typically affects the hands and the feet and the arteries of the hands and the feet, and that's called Berger's disease. Um, the technical term, thromboangiitis obliterans. Okay, maybe after we talk about it, well, that'll make more sense. But basically, what it is it's a recurring inflammation of the arterioles that supply blood to the hands and the feet. So if you have inflammation and swelling of the arteries, that's going to cause reduced blood supply to the fingers and also the toes um, uh, where those arteries are affected, right? And that's going to set up ischemic damage to your fingers and toes. There won't be enough oxygen and nutrients getting to the end of the digits, and that's going to set up ulcers on your fingers and toes and gangrene, which is, of course, infection of those areas. Okay, so what are the contributing factors? Well, we think it's partly genetic, but smoking is a big, big risk factor for this. Okay, so smoking can set up inflammation within these blood vessels, leading to swelling and edema and blockage of those arteries, resulting in ulcers and gangrene of the digits. Okay, so what kind of symptoms? Well, if it's an artery um, going down the leg, patients will complain of intermittent claudication because the artery is becoming occluded. They may complain of very painful sores on their fingers and their toes, again, because the tissue has died from lack of blood supply. And as the condition gets worse, ulcerations, gangrene, and even amputation may be required because of the infection. Okay, so Berger's disease is different than Raynaud's syndrome because Raynaud's syndrome doesn't have inflammation. It's just irritable, twitchy arteries in the fingers that vasoconstrict every once in a while. Okay, that's not to say that if you have severe Raynaud's syndrome that you can't have some ulcers or skin breakdown at the end of your fingers. You can. But Berger's disease is more inflammation, so it tends to be more aggressive. Okay, and it can lead to gangrene and amputations. So what are the interventions? Smoking cessation is a huge one. Avoiding cold is there again. Okay. Any constrictive clothing, of course, just because you don't want to irritate those arteries that are inflamed. Now, you would think that anti-inflammatories might help, such as ibuprofen or maybe corticosteroids. They haven't been shown to be very helpful. And on top of that, anticoagulants haven't been shown to be very effective either. Okay, so think of Buerger's disease as diffuse inflammation of the small arteries of your hands and feet, leading to these ulcers and gangrene. Okay, next slide, we're going to move over to the venous side. So we've spoken about arterial conditions of the periphery, such as intermittent claudication, ischemic leg, Raynaud's disease, Buerger's syndrome, or Buerger's disease. Now we're going to talk about some venous issues. So we're going to discuss venous thromboembolism, venous insufficiency. So venous insufficiency is just another term for the veins aren't working properly to get the blood back up the leg to then drain into the inferior vena cava. So there's a problem with the veins, okay? And lastly, varicose veins we'll talk about as well. Okay, so the umbrella term that we use is venous thromboembolism. Okay, so let's just break that down. So venous is something's occurring in the vein. Thromboembolism. So there's a thrombus that's forming in a vein, typically in a leg. And if a piece breaks off of the thrombus, it'll embolize, it'll travel to the lung. So we call it venous thromboembolism. Okay, which basically is another term for deep venous thrombosis. Okay, so a DVT is really a venous thrombosis. And if a piece breaks off and travels to the lung, we'll call it a pulmonary embolus. Okay. So what are the risk factors for developing venous thromboembolism? Well, whatever the risk factors are for forming a blood clot in one of the veins of your leg, well, that's going to be the risk factors for developing a pulmonary embolus, because the pulmonary embolus originates from the venous thrombosis. Okay, so we think of it in broad terms first, and we call the overall term Virchow's triad. So Virchow's triad are three items that will contribute in some way that can result in a deep vein thrombosis. Okay, so anything that causes venous stasis. Okay, anything that slows down the return of blood up your legs and then back into the inferior vena cava is going to increase your risk for developing a venous thrombosis. Anything that injures the vein, so any kind of injury to the vein is going to increase the risk that there's going to be clot at that site, because the vein's been injured and now the endothelial lining is injured, and of course clotting occurs. Okay, and lastly, any condition where the person is hypercoagulable, meaning they're more prone to their blood clotting in general. Okay, so we'll talk about that. So think of venous thromboembolism in terms of those three parts of a triangle. Anything that slows down the blood, anything that causes injury to the vein, and anything that makes the blood clot more easily. And it'll be explainable by one of those for sure. So now let's look at the risk factors. Surgery. Well, surgery slows down the flow in your legs because you're not moving. Okay, so surgery is a risk factor for sure. Heart failure. Well, if your heart's failing, it's not able to receive the blood as well coming from the inferior vena cava and the superior vena cava. So it backs up into the legs and you have venous stasis. So heart failure makes sense. Immobility. Well, immobility leads to venous stasis because you're not moving your legs. And really, in order for blood to flow up your leg properly, you need to be mobile. Okay? Pregnancy. Pregnancy causes or leads to a lot of compression of the veins in the pelvis. And if you compress the veins in the pelvis as you get on in pregnancy, that's going to lead to venous stasis. Okay? Oral contraceptives. Why? They thicken the blood. Okay, so estrogen in oral contraceptives stimulate protein production and increase clotting factors, which will thicken the blood, leading to hypercoagulability. Active cancer, why is it a risk factor? Hypercoagulability. Okay, so if someone has active cancer, because of all the inflammation that's occurring with cancer, they have blood that tends to clot more easily in general. A perfect example of this is someone with pancreatic cancer. They often develop DVTs because of the active cancer they have. Okay? So again, think of Verko's triad, and you'll be able to fit in any risk factor into one of those. Okay? So endothelial injury, let's just give an example. You had a crush injury to your leg and you injured the vein. Well, now you're at risk for a DVT, right? So you had some kind of surgery to your leg, and now not only are you immobile, which causes venous stasis, you may have had some venous injury, so there's the endothelial injury, right? So always think of it in terms of those three parts of a triangle. Okay, so what do we find in someone with a DVT? Well, typically their leg is painful, okay, often because it's so swollen. It's often warm, and with the edema comes increased circumference of the leg, okay? So it's tender, it's swollen, it's warm, and there's increased circumference, okay? And this is all because of a blocked vein, right? So if the veins allow blood to leave your leg, when they're blocked, you're going to get backup of blood, which is going to lead to the edema, the warmth, and the increased circumference. So they all make sense. The limb pain is from all the swelling that's occurring in the leg. Okay. So what's venous insufficiency? So typically your veins accept blood from the arterial side in your legs, and the veins join together and form bigger and bigger veins that then travel up the leg. These veins have one-way valves in them. So when the blood travels up, it can't spill back down the vein, right? It's a one-way valve, which allows for blood to flow up the leg into the inferior vena cava. Okay. So if there's any disease process or injury to these valves, they won't be functional anymore. They'll leak the blood back down the vein and cause swelling of the leg. Okay, because there's blood that's pooling in these veins that don't have normally functioning valves. Okay, so what are risk factors? So if you have an occupation where you have prolonged standing or sitting, well, you have poor blood flow in your veins back up your leg because you're not moving very much, and really movement requires contractions of the muscles in your legs, which then squeeze the veins to move the blood up the leg. So when someone is sitting or standing for a long time, they're not moving their legs. So there's venous stasis, there's blood pooling, because you need those contractions of muscles around the veins to move the blood up the leg. right? So, and over time, that's going to put a lot of stress on the valves because there's back pressure from all this blood pooling. Okay, so sitting and standing is a risk factor for venous insufficiency. Obesity, well, obesity is a risk factor because there's excessive or extra tissue of the legs, especially when someone bends the knees or crosses their legs, and that's compressing the vein behind the knee, or even when they're sitting and their hips are flexed. That's compressing the vein in there, and it's causing backup of blood, and over time it causes venous insufficiency and swollen legs. Okay, and lastly, pregnancy. So this is a temporary cause of venous insufficiency, but it can cause valve damage, right? Because there's same thing. There's backup of blood in the venous system because of the enlarging fetus in the pregnancy, and that can cause damaged valves and venous insufficiency even after the pregnancy, right? Because the valves have become incompetent. They're not functional anymore. So what are the symptoms of venous insufficiency? Well, the blood can't get up the leg. So you're going to get leg swelling. And when you get leg swelling, the bigger and bigger the legs get in terms of edema, well, the skin overlying these really swollen legs will start to get dry, and the skin will start to break down, and that's called stasis dermatitis. Okay, dry, scaly skin. You'll definitely see this. Now, that dry, scaly skin can then start to break down, and people get venous stasis ulcers. Okay, and often you'll find these on the inside part of the ankle called the medial malleoli. And on top of that, because the skin is scaly and dry, they're developing venous ulcers, they're at a really high risk of getting a bacterial infection subcutaneously called cellulitis. Okay. Okay, so varicose veins. So these are superficial veins in the legs, so we can see them visually, and that's partly why a lot of people have a difficult time with varicose veins because they're quite visible, these distended, twisting veins in the legs. Okay, they don't have a specific cause. We think that it has more to do with the genetic makeup of the person's own tissue. And some veins are just more prone to dilating and twisting. Okay, so let's look at some risk factors though, okay, for varicose veins. So definitely female is a risk factor. Age greater than 30 is definitely a risk factor. There's prolonged standing and sitting again because of that back pressure of the blood that's pooling in the veins. Pregnancy, for sure, because of the back pressure. Obesity, again, because of that back pressure of blood that's constantly dilating these veins. And family history. And that's where genetics comes in. So if your mother has varicose veins or your grandmother has varicose veins, you have a higher risk of developing varicose veins. Okay. So what do we expect to see? Well, these distended, twisting veins superficially. Some people complain of leg fatigue, aches in the legs, cramping of the legs. Now, sometimes if one of these gets nicked or cut, they can really bleed. Even though they're just veins, they're actually dilated veins and they just don't close very often. And sometimes we actually have to stitch them because once they're open, they just don't seem to want to stop bleeding. Okay, so it's not an artery that's bleeding, but still they tend to ooze and ooze and ooze until we stop them. Okay, either with pressure or with stitches. Now, what can we do for varicose veins? Well, it often comes down to wearing compression stockings, regular exercise, elevation of the legs, some weight loss can help. And there's also medical procedures such as sclerotherapy, where they will burn certain parts of the veins, and then the blood won't flow through them anymore, and the varicose veins will disappear. And that can be with laser. So laser surgery can be used for the same purpose. Okay. And lastly, a much more aggressive surgery is vein stripping, where they just basically put you to sleep and they strip out all these varicose veins. But with sclerotherapy, where they just burn the veins and they shrink down, or laser surgery, varicose vein stripping isn't as common anymore. Okay, so let's just look at this slide, peripheral venous diagnostic procedures. Okay, the first one is a laboratory test called a D-dimer. And a D-dimer is basically a blood test that we measure that's detecting breakdown products of a clot. So if someone has an active clot, um, part of the clot is forming and part of the clot is breaking down. And that's a constant process. And we're picking up a D-dimer, which is the breakdown product of clots. So it's an indication that there's an active clot in the system. It's not a super accurate test, though. So just because you have a positive D-dimer, it doesn't mean you have a blood clot. So it's not definitive. It just means that there's something in the body where there's active breakdown and production of clots. So for example, if you fell and you bruised your arm, well, you're going to have a positive D-dimer. If you had some kind of an injury, you might have a positive D-dimer. But we use this test knowing that if it's positive, we have to go on to a more definitive test. So it's only useful if it's negative, and we don't have to go on to another test. Okay, so D-dimer, yes, it's a test for us to be have increased suspicion for a deep vein thrombosis or a pulmonary embolus. Okay, what's a more definitive test? Well, that's an ultrasound of the leg. Okay, so if someone has a red, swollen, tender leg, and we're suspecting a deep vein thrombosis, well, we're going to do an ultrasound, and an ultrasound looks directly at the veins, and it'll tell us definitively, yes, there's a blood clot within the vein, or no, there isn't. Okay, so we get fantastic images with an ultrasound. We can see the inside of the veins going up and down the legs, and we just scan all the way from the groin down below the knee, looking for any potential blood clots. Okay, so let's look at the three different conditions and look at some patient education surrounding them. So DVT, well, so the TED hose, so what does that stand for? So that is the thromboembolic deterrent stockings, right? And they're basically the same as compression stockings. So thromboembolic deterrent stockings. Okay, so when someone puts these on, you really want to make sure that there's no wrinkles that are going to irritate the skin when the stockings are on, right? And obviously they need to remove them for baths or showers. Regular ambulation, so at least 3 times a day. Remember, when you're walking, you're actually using leg muscles. Leg muscles compress the veins, which helps the blood flow up the leg and prevents a DVT. No massaging of the leg. So if someone is at risk for a DVT, we certainly wouldn't want to massage an area where a potential DVT is and then break off a piece that could lead to a pulmonary embolus. That's not a very likely event, but still, there's no reason that we should be doing that. And in actual fact, I've seen some deep vein thrombosis on ultrasounds where you can just see a piece that's waiting to break off. Okay, so massaging of the leg in the setting of a DVT or prevention of DVT, not a good idea. So no massaging. Venous insufficiency, okay, so those valves aren't working well. Patients end up with swollen legs, stasis dermatitis, ulcers, and then cellulitis. So the TED hose stockings are a good idea here. Leg elevation above the level of the heart while supine. It's really hard to get your legs above the level of your heart if you're not lying flat. And then, of course, avoiding cross legs, right? Varicose veins, again, compression stockings or thromboembolic deterrent stockings, minimizing sitting and standing for prolonged periods of time because you're going to have poor flow of blood up the leg. It's going to cause more pressure on the veins because the blood's not getting up the leg, and more stretching of the veins leading to more varicose veins. Okay. Okay, so let's look at some anticoagulants. And we're discussing deep vein thrombosis, but anticoagulants are used for a variety of conditions. So, sure, they could be used to treat a DVT. They can actually be used to prevent a DVT in someone who's in hospital and is at high risk for developing a DVT, such as a post-op patient who's immobile in bed. Okay. We use anticoagulants to treat pulmonary emboli. We use anticoagulants to treat atrial fibrillation. So there's an assortment of conditions where we use anticoagulants. So let's talk a bit about them, the different types. So heparin. Well, heparin is an anticoagulant, and it inhibits the intrinsic side of the coagulation cascade. Okay. So what do we need? Well, before I mention that, we can treat someone or we can give somebody subcutaneous heparin while in hospital. So a heparin shot subcutaneously once or twice a day to prevent DVTs. So someone who's lying in bed, they're sick with pneumonia, they're not able to get up very often, we can try and prevent them with subcutaneous shots of heparin or with a low molecular weight heparin such as Lovenox, which is right below it. Okay, so prevention of DVTs. We can also treat DVTs with heparin. So heparin comes in an IV formulation, and that's how we would treat a DVT. How do we monitor heparin? With PTT, right? So the PTT, we usually like to see between 1.5 and 2 times normal. Okay, don't confuse that with an INR. Okay, a PTT is to monitor heparin. So what else do we need to monitor if someone is on heparin as an anticoagulant? We definitely need to do frequent CBCs because as an adverse effect, heparin can cause heparin-induced thrombocytopenia. So you can imagine someone's receiving IV heparin to treat their DVT, and it can impact their platelet count and make it drop significantly. So not only are they on an anticoagulant now, but their platelet count is lower. So they are at higher risk for bleeding. So we definitely monitor platelet counts. Okay. What's the reversal agent for heparin if the PTT became very elevated and the patient was bleeding? Well, it's protamine sulfate. Usually we don't need to use it because if the PTT gets too high and the blood becomes too thin, we can just back off on the heparin and the PTT starts to come back down relatively fast. Okay, so it's not like it takes days for the PTT to come back down once we've reduced or stopped the heparin. Okay, so we rarely need protamine sulfate, but it's just good to know that's the reversal agent for heparin. Lovenox is a low molecular weight heparin, and it's given typically subcutaneously. And again, we can treat it as prevention of a DVT, or it can be used in full doses as the treatment of DVTs. Okay, and in fact, in the treatment of PEs. Remember, a PE is just a piece of a thrombus that's broken off and traveled to the lungs. Okay, there's no monitoring necessary for Lovenox or for any of the low molecular weight heparins. Okay, they're weight-based, no monitoring required. Okay, next anticoagulant, warfarin. So warfarin is a vitamin K antagonist. It's given orally, and what it does is it suppresses the production of vitamin K dependent clotting factors in the liver. So it reduces their production because it antagonizes vitamin K. That takes time to start to work once someone is on warfarin. It can take 3, 4, 5 days for it to reach a therapeutic level of either a PT or, more commonly, an INR. Okay, so we monitor warfarin with an INR, and we like to see it usually between 2 to 3. Okay, so sometimes patients need to be given heparin or a low molecular weight heparin, which work immediately, by the way, and then they're started on warfarin. And once the warfarin reaches a therapeutic level in the blood, and the INR is between 2 to 3, then the heparin or the Lovenox can be stopped. Okay, so warfarin takes time to work. We start with heparin or Lovenox. We keep them on. We keep the patient on them until the warfarin is therapeutic. Okay. Now, if someone's warfarin they're taking a dose that's causing their INR to become higher and higher and higher, meaning their blood is getting thinner and thinner, we can reverse the effects of warfarin with doses of vitamin K. Okay, so say somebody's INR is 5, they're not bleeding, but we don't really want them to have an INR of 5. We can give them a dose of either oral vitamin K, subcutaneous vitamin K, or even IV vitamin K. Usually we'll just give them an oral dose of vitamin K. Okay, and then adjust their warfarin dose so that their INR doesn't go as high. Okay. Now remember, vitamin K is going to take, at least 12 to 24 hours to bring the INR back down. Okay, so yes, it's a reversal agent, but if someone's bleeding while on warfarin, giving them vitamin K is not going to fix the bleeding today. Okay, so often we have to replace their clotting factors with a product that has clotting factors in it, or with fresh frozen plasma. Okay. Now there's new anticoagulants which inhibit the coagulation cascade that you're going to hear about, such as apixaban, rivaroxaban, and these are relatively new anticoagulants, and they're meant to replace warfarin. And the advantage of them is that they don't require any monitoring, which is fantastic, right? They don't need an INR. And many patients are being converted from warfarin to rivaroxaban, apixaban, because of this ease of use and no requirement for monitoring the INR. Okay. All right, so the last medication, thrombolytic therapy, so tissue plasminogen activator, TPA, is one of them. We don't usually use this for a DVT at all or ever. But say someone has a massive pulmonary embolus, so a huge clot has broken off and traveled to their lung, or in patients with an ischemic stroke, so a clotted artery to the brain, if they present in less than 4.5 hours, seems like that time range is lengthening longer, the longer and longer we talk about it. TPA tries to break up the clot. Okay, so we call it, quote, the clot buster. Okay, so someone who has a massive pulmonary embolus and they're dying, we could offer them TPA. Okay, and just as the term is saying, tissue plasminogen activator, it goes to plasminogen, it converts it to plasmin. What does plasmin do? Breaks up the clot. So anyone who's receiving TPA, what we really hope happens is that this massive clot, whether it's in a blood vessel in their brain or a pulmonary embolus in their pulmonary artery, we hope that it breaks up. Remember that this can cause massive bleeding around the body, because not only is it breaking up the clot in the lungs or in the brain, it's going to break up any clot. So typically there's a list of questions that we ask patients prior to giving them TPA, and they mainly center around the risk of bleeding. Have you had recent surgery? Has the patient had recent CPR? Do they have severe hypertension? Have they ever had a hemorrhagic stroke? And so on and so on. So there's many contraindications to giving TPA, and they usually center around the risk of causing bleeding. Okay, so let's just talk about a few therapeutic procedures that occur with venous issues. So the first one at the top is someone who has recurrent DVTs. So say somebody has a DVT. How do we treat it? Well, we treat it with an anticoagulant, such as warfarin, or one of the newer anticoagulants, such as rivaroxaban or apixaban. Okay. Now, we can still use IV heparin at the beginning, or we can still use Lovenox as a treatment. But remember, most people don't want to take injections of Lovenox for the next 4 to 6 months, which is how long we treat a DVT usually, right? And they're not going to stay on IV heparin. So we're going to transition them to an oral medication, such as warfarin or one of the newer anticoagulants that I mentioned. Now, say somebody's on an anticoagulant and they get another DVT. Well, that's kind of concerning, right? They're being treated for a DVT, and if we assume that they're being adherent to the medication, their blood is anticoagulated. So if someone's getting recurrent DVTs, another option is to actually put a filter in the inferior vena cava, and it almost looks like an umbrella. And they put this little tiny umbrella, they feather it from the groin, and they put it into the inferior vena cava, and it opens up. And it becomes almost like a umbrella filter. And if a clot travels from the leg, since we know that's where most deep vein thrombosis occur, it's going to arrive at the filter, and it won't be able to travel any further, and it'll prevent a pulmonary embolus. Okay, so that's what an IVC filter is for recurrent DVTs. Okay, or it could be used for someone who's just unable to take anticoagulants for whatever reason. Say they have massive bleeding on anticoagulants and they just can't take them. Well, they could be offered a IVC filter. Okay. Venous insufficiency. What kind of treatments can they receive? Well, they can have wound vacs put on them, and they can be offered hyperbaric oxygen chambers, which has been shown to improve healing of venous insufficiency ulcers and wounds. Okay, typically wound vacs are applied to these ulcers and wounds. And finally, debridement. What does debridement mean? Well, we're going to actually clean around the wound and remove, often with forceps, tissue forceps, we're going to remove all the dead and devitalized tissue. Because if you have dead tissue on the skin, it's just a place to get infected. There's no blood supply to it. It's dead, right? So debridement is very important. What about for varicose veins? Well, we already spoke about this. So they can go for sclerotherapy, where chemicals are used to scar down the veins, and then the blood flow doesn't go through them anymore. It redirects somewhere else and shrinks down the varicose veins. You can use laser therapies to scar down these veins, these varicose veins. Okay, and basically the whole idea is let's try and block the blood supply in these superficial veins so that the varicose veins disappear. Okay, and a much more aggressive treatment would be vein stripping, which is basically just opening the leg and stripping all the veins out of the leg. Okay, I would say the other options are more frequently done. Okay, the sclerotherapy, the laser therapy, just because vein stripping is much more invasive. Okay, so on these polling question type slides, I just do the questions at the back of the ATI chapter. So this is ATI chapter 35. So number 1, a nurse is caring for a client who has chronic venous insufficiency in a prescription for thigh-high compression stockings. Which of the following actions should the nurse take? Elevate the elevate the client's legs for 10 minutes, 2 to 3 times daily, while wearing stockings. That's not really required. The stockings are really to provide the compression so that it improves blood flow up the legs. Okay. Apply the stockings in the morning upon awakening and before getting out of bed. Yes, you would like to do that before they get out of bed and before the legs start to become edematous, right? So that one makes sense before actually getting up. C, roll the stockings down to the knees to provide to relieve discomfort on the legs. No, that's not the case, right? You wouldn't roll down the stockings to the knees because then they're not going to have as much effect. Okay. By the way, these stockings can be hot and uncomfortable because they're providing some force, some pressure to the legs. D, remove the stockings while out of bed for 1 hour, 4 times a day to allow the legs to rest. No, that's not the case either. That's just going to allow edema to set in. And on top of that, they'll be very difficult to get back on. Okay, so the answer is B. Next question, number 2. A nurse is assessing a client who has chronic peripheral arterial disease. Okay, so they have chronic blockage of the arteries to one or both legs. Which of the following findings should the nurse expect? Edema around the ankles and feet. No, that would be more of a venous problem. A problem with the blood getting out of the legs and back to the heart. Ulceration around the medial malleoli. No, those ulcers that occur at the medial malleoli are typically venous ulcers from venous issues. If you had ulcers from lack of blood flow, the ulcers would typically be at the furthest part of the leg, which is the toes, right? The toes get ulcerated because they have the furthest blood flow. C, scaling eczema of the lower legs with stasis dermatitis. No, that is an issue with venous insufficiency. They get swollen legs, then they get dry, scaly skin on top of it, which is prone to cellulitis. D, pallor on elevation of the limbs, and rubor, so redness, when the limbs are dependent. Yes, when you lift the leg up, you're getting gravity to work, and it makes it even harder for the blood to flow to the limb. So paleness upon elevation and redness when you put the leg dependently. So the answer is definitely going to be D. Okay, let's continue. Number 3, a nurse is teaching a client who has a new diagnosis of peripheral artery disease. Which of the following instructions should the nurse include? Wear tightly fitted insulating socks with shoes when going outside. And no, tightly fitted insulating socks. I don't think you should really have tightly fitted insulating socks for anything. I mean, maybe for Raynaud's disease well, they shouldn't even be tightly fitted for that, but they should be insulated. B, elevate both legs above the heart when resting. No, this person has peripheral artery disease. If you elevate the legs will turn pale. So you wouldn't want to do that. C, apply a heating pad to both legs for comfort. Now, dry heat to the legs for peripheral arterial disease? No, that wouldn't do anything. That wouldn't help the blockage at all. So I don't think that's the answer either. And D, place both legs in dependent position while sleeping. That's easier said than done, but that's the answer. So putting the legs below the level of the heart is going to allow gravity to work and help improve blood flow to the legs. So the answer is D, even though it's not really that easy to do. Okay, that is the answer. Number 4, a nurse is teaching a client who has a new prescription for clopidogrel. Okay, so clopidogrel is an antiplatelet drug. It works similarly to aspirin. It inhibits platelet adhesion. Okay, which of the following instructions should the nurse include? Avoid taking herbal supplements while taking this medication. Absolutely. Some herbal remedies, such as ginger, can have blood thinning effects. So we're very careful with the over-the-counter and herbal remedies while on clopidogrel. Monitor for the presence of black tarry stools. Absolutely. Black tarry stools is melena, which indicates an upper gastrointestinal bleed, and clopidogrel definitely puts people at risk for ulcers or bleeding ulcers, and they will continue to bleed if on clopidogrel. So definitely B. Take this medication when you have pain. No, it's an antiplatelet medication. It's not for pain at all. Schedule a weekly PT test. No, you don't need any blood testing while on clopidogrel, including PT or PTT or INR. Not required. Okay. PT is actually for warfarin. In actual fact, we use INR much more commonly for warfarin. INR gives us a level of how thick or thin the blood is, and we like to see it between 2 to 3 while on warfarin. Okay, no testing for clopidogrel. Limit food sources containing vitamin K while taking this medication. Not true. That is for warfarin, because warfarin inhibits vitamin K dependent clotting factors. So limiting food sources that contain vitamin K would be referencing to warfarin, not clopidogrel. So the answer is A and B. Okay, last question, number 5. A nurse is caring for a client who has a deep vein thrombosis and has been taking unfractionated heparin for 1 week. Okay, so IV heparin. 2 days ago, the provider also prescribed warfarin. The client asked the nurse about receiving both heparin and warfarin at the same time. Which of the following statements should the nurse give? I will remind your provider that you are already receiving heparin. Sorry. No, heparin is used initially for a DVT because it works immediately. And so we start warfarin, but warfarin takes 2, 3, 4, 5 days to really become therapeutic. So you need to bridge the warfarin with heparin so that they're fully anticoagulated. And then once we see that the warfarin has caused the INR to go between 2 to 3, then we can stop the heparin. B, your laboratory findings indicate that 2 anticoagulants were needed. That's not true. Okay, no laboratory finding would indicate that 2 anticoagulants were needed. C, it takes 3 to 4 days for the therapeutic effects of warfarin are achieved, and then the heparin can be discontinued. Absolutely. So we're using heparin initially, as a bridging anticoagulant until the warfarin is therapeutic. D, only one of these medications is being given to treat your deep vein thrombosis. No, that's not the case. If we're using heparin, we give it at the beginning, then we start the warfarin and wait for the warfarin to become therapeutic and then stop the heparin. Okay, so the answer there is C. Okay, so let's move on and talk about hypertension. So when we talk about hypertension, we're talking about the arterial side, right? The pressures that we're detecting with our monitor on the arterial side. And there's two pressures, the systolic pressure and the diastolic pressure. What's the systolic pressure? Well, it's the pressure exerted on the inner part of the artery during a systolic contraction of the left ventricle. Okay. What's diastolic pressure? Well, it's the pressure exerted on the inner part of the arteries during relaxation of the left ventricle. And that's why we get those two numbers, the systolic and diastolic blood pressure. Now, typically, as we age, we start to get an increase in systolic hypertension. Okay, the arteries are getting stiff, so during contraction of the left ventricle, the pressure rises really quickly, and they develop, and they have systolic hypertension, right? So both numbers are important, though. So systolic hypertension is a risk factor for a variety of conditions, and also diastolic hypertension. So whether we're talking about atherosclerosis in the arteries, renal failure, hemorrhagic strokes, an assortment of injuries to organs, the systolic or the diastolic hypertension are both important. And also remember that your blood pressure, when it's elevated, is the pressure that your heart has to pump against, right? So what is the heart having to pump against during the next contraction? Your diastolic blood pressure. So if you have a really elevated diastolic blood pressure, that poor left ventricle is going to have to pump against high pressures, and it's going to hypertrophy. It's going to thicken because the left ventricle is saying, well, I'm pumping against high pressures, I'm going to have to enlarge. So you get left ventricular hypertrophy. And over the years, that poor left ventricle is pumping against high pressures, and you can start to develop congestive heart failure. The left ventricle is now saying, I've hypertrophied, I've thickened, but now I'm starting to fail because I'm having to pump constantly against these very elevated blood pressures. Okay, so when we think of hypertension or high blood pressure, the vast majority of people are going to have primary hypertension, meaning we don't think there's an underlying disease causing your hypertension. And that's the vast majority of people. Okay, so it's not like everybody that comes in with hypertension, we're going to do a whole bunch of tests on them looking for the 5% of people that have secondary hypertension. Okay, so the average person that comes in with hypertension, we actually assume they have primary hypertension, unless there's a clinical reason to make us suspect that they have an underlying cause that may need to be corrected. So we would call that secondary hypertension. Okay, so let's look at the risk factors of primary hypertension. Okay, they're not the cause, they're just risk factors. So idiopathic is the first one, meaning we don't know the cause. We have no idea. Okay, and that's the majority. That would be the majority of people with primary hypertension, is just idiopathic. Okay, genetic, yes, it runs in people's families for sure. So if your parents have hypertension, you're at risk for having hypertension, for sure. Lifestyle. definitely smoking, because it causes vasoconstriction. The nicotine is a powerful vasoconstrictor, and it actually makes your heart beat faster too. Contraceptive use, yes. Contraceptive agents have estrogen and progesterone. They can increase blood pressure a bit. Okay. Post-surgical, I'm not really clear on that one, so I'm going to leave it. I mean, if you have post-surgical pain, sure, that can cause hypertension because of the pain, right? But I'm not really clear on post-surgical. African Americans have a higher risk of having hypertension, and also treating their hypertension can be more challenging. Okay, if you recall, there's certain antihypertensive that we tend not to use as commonly in African Americans, such as ACE inhibitors and ARBs. They're not first line. We can still use them. They're just not typically used as first line in African Americans because they're not as effective and they have more adverse effects. Okay, so we really consider hypertension as the silent killer, right? So why is it the silent killer? Because it really doesn't give you any symptoms until something devastating happens. So until you have left ventricular failure, until you have a myocardial infarction, until you have a hemorrhagic stroke, or you have diffuse atherosclerosis through your arteries causing organ failure. Okay, hypertension is hard on the kidneys, so it results in renal failure. So someone might present in renal failure after years of having had hypertension. Okay, so it's really the silent killer until something serious occurs. Okay, so when we're talking about secondary causes, we're saying that, well, there's something in the body, there's a disease process in the body that's causing hypertension as one of its effects. Okay, so somebody who has kidney disease or kidney failure, well, they often have hypertension because they're not able to get rid of all the fluid. And kidneys usually are the filters of the body to regulate blood volume. Cushing's disease, where you're making excessive cortisol, well, cortisol not only retains fluid in the kidneys, but it has direct effects on the blood vessels, causing hypertension. Okay, so patients with Cushing's disease, which is excessive cortisol, almost always have hypertension. Hyperaldosteronism, so you can actually have a tumor in your adrenal gland that's producing excessive aldosterone. And if you remember what aldosterone does, it reabsorbs sodium in the kidneys. It gets rid of potassium. But during the process of reabsorbing sodium, it's reabsorbing fluid. So when you reabsorb all this fluid, it leads to hypertension, right? So remember, Cushing's disease, what causes that? Well, it could be caused by excessive glucocorticoids that are administered to the patient or an adrenal cortex tumor. Hyperaldosteronism, where does that come from? Adrenal cortex tumor. Pheochromocytoma is an adrenal medulla tumor, which is producing tremendous amounts of epinephrine, norepinephrine. Those are powerful sympathomimetics. They cause vasoconstriction all throughout the body. So a patient with a pheochromocytoma is going to have episodes of severely elevated blood pressure when epinephrine and norepinephrine are being secreted, and then it's going to go back to normal, and then it's going to increase again because more epinephrine and norepinephrine is being secreted by this adrenal medulla tumor. Okay, so the symptoms they have are severe headaches, flushing, sweating, severe hypertensive episodes, and then they settle only to return again. And that's from the tumor producing epinephrine and norepinephrine. Okay. let's so I'm not going to go into brain tumors. That's not a common cause. Encephalitis, that's not a common cause. Some medications can cause secondary hypertension. So if you remember, if you're taking some kind of sympathomimetic um, for your cold symptoms, such as Sudafed, which is pseudoephedrine, or you're taking a nasal decongestant, or you're taking a lot of albuterol, which is an asthma medication. That's a beta 2 agonist. You might get some hypertension as an adverse effect. Okay. Pregnancy, I'm going to tell you most of the time in pregnancy, so a normal pregnancy should have a lower blood pressure. So women who are pregnant have a lower blood pressure, and that makes sense. You have blood vessels that in the umbilicus that are, sorry, in the placenta that are feeding the fetus. So the blood pressure is usually lower in someone who's pregnant because there's blood flowing to the fetus through a new system. Now, women can develop preeclampsia, which is a condition in pregnancy where you get hypertension, right? But in a normal pregnancy, women are typically never hypertensive. They should be actually a bit on the lower side of blood pressure. Okay, so a pregnant woman who has a normal blood pressure of 125 on 70 when she's not pregnant, she might have a blood pressure of 100 on 80 or 100 on 60 when she's pregnant, and that's normal. Okay, so it's only when we see elevated blood pressures in pregnancy that we suspect that the person might have preeclampsia. Okay. Okay, so expected findings in someone with hypertension. The first one would be by far the most common, asymptomatic. Okay, remember, silent killer until something bad happens years later, like a hemorrhagic stroke, a heart attack, renal failure. Okay. Now, are the other ones possible? They are, sure. If you have severe hypertension, can you have facial flushing, some dizziness, headaches, fainting? You can. Notice that, um, item number 2 all the way down to item number 5, it's neurological. Headaches, flushing, dizziness, fainting, right? Um, Retinal changes and visual disturbances. Okay, that can be from severe hypertension because if the blood pressure is super high, um, the blood vessels can actually rupture in the retina, leading to a retinal hemorrhage and visual disturbances. Okay, but I'm going to tell you, for the most part, asymptomatic is the most common. Okay, we rarely see nosebleeds from epistaxis. Now, some people can come in with high blood pressure with a nosebleed because they're so anxious, but most nosebleeds are not from hypertension. Okay. So the way I would think of it is if someone has a fantastically elevated blood pressure, and I'm talking about over 200 systolic, sure, they can come in with headaches, neurological symptoms, confusion, flushing. They can actually come in with chest pain because their heart is having to pump against these tremendous pressures, right? So they can develop some angina. Okay, but the average run-of-the-mill person with hypertension is asymptomatic. Okay, so let's look at the definition of hypertension, and it's changed over the years, right? So it used to be that it was a blood pressure of a systolic blood pressure of 140 or greater, or a diastolic blood pressure of 90 or greater. But as time goes on, we just start to play with those numbers a bit, and we want better numbers. So if you were below 140 on 90, we would have stated that you actually had a normal blood pressure. Okay. And by the way, this is typically on repeated readings, not one reading, right? So if we get one reading, it's really not very useful. We want many readings to diagnose hypertension. We're committing people to not only lifestyle changes, but also potentially medications. Okay. So let's look at the levels of hypertension. So now we really consider normal as less than 120 on 80. Okay. And we're going to call people that have a blood pressure between 120 to 139 systolic and 80 to 89 diastolic as having pre-hypertension. Okay. So it's made it a bit more complicated. Now, stage 1 hypertension, okay, 140 to 159, or a diastolic of 90 to 99. Stage 2, greater than 160, right? So 160 or greater systolic, or 100 diastolic or greater. Okay, so we've made it a bit more complicated. Okay. In someone who has a normal blood pressure, okay, well, they just need a follow-up in a few years to reassess it, right, to see if they're still normal. In someone with pre-hypertension, they get an earlier follow-up, typically in a year, and maybe some lifestyle changes as well, right? Lose some weight, get some exercise, stop smoking, decrease salt intake. Okay. With stage 1 hypertension, typically they'll be reassessed on in a shorter time frame, so within a month. Okay. Stage 2, again, so they have higher pressures. We want to confirm that those are the blood pressures. So we'll have them come back, and if we confirm that they have these significantly elevated pressures, then they're going to need treatment, plus, of course, lifestyle changes. Okay. Now, the bottom sentence there is just a reminder that as we get older, our systolic blood pressure starts to climb because our arteries are getting stiff. So when that heart pumps blood, the arteries are really stiff and the systolic blood pressure jumps up. So now we allow a blood pressure of 150 instead of 140 in someone who's older than the age of 60. If we didn't do that, we would start to capture the majority of people over the age of 60, right? So we don't want to say that, 95% of the population has systolic hypertension, because we have to make do for the fact that their arteries are stiffening a bit. So in someone who's over the age of 60, hypertension is 150 over 90 or greater. Okay. Okay, so let's talk about hypertensive crisis conditions. So hypertensive crisis is more of an umbrella for two separate conditions. And it's where the systolic blood pressure is typically greater than 180, or the diastolic blood pressure is greater than 120. So hypertensive crisis is referring to two conditions. The first one is hypertensive urgency. So that's where the blood pressure is significantly elevated, but there's really no symptoms. So there's no chest pain, there's no neurologic symptoms, there's no renal failure. It's just that we've noticed that the blood pressure is severely elevated. Okay? And really the plan with hypertensive urgency is to try to bring the blood pressure down within normal ranges within 24 to 48 hours. And there's an assortment of medications for that. There's labetalol, which is a beta blocker. We can use captopril, which is an ACE inhibitor. Clonidine, we probably wouldn't use very much anymore. That's that alpha-2 agonist that works in the brain. So it just causes a lot of side effects like dry mouth. It can cause bradycardia, fatigue, headaches. Okay. So really think of hypertensive urgency as, yes, the blood pressure is really elevated, but there's no organ damage. Hypertensive emergency is, yes, the blood pressure is very elevated, so greater than 180 systolic, greater than 120 diastolic, plus there's organ damage. We're seeing that there's organ damage, such as pulmonary edema, so fluid in the lungs. There might be congestive heart failure from it. There may be some neurologic deficits, such as confusion. There might be acute renal failure. So it's hypertension plus end organ damage. Okay, that's a hypertensive emergency, and we have to do something about it now because we're detecting that organs are being damaged. Okay, so what do we want to do? We want to gradually bring down the blood pressure starting now. It's not starting within the first 24 or 48 hours, it's actually starting now. Okay, and there's an assortment of medications that we can use again. So the first two, nitroprusside, well, that's a vasodilator. It's going to open up the arterioles. Nicardipine is just a type of calcium channel blocker. It's going to open up the blood vessels. Labetalol, a beta blocker. It's going to slow down the heart. It's going to decrease contractility of the heart and lower the blood pressure, which is going to reduce the workload on the heart. Nitroglycerin, vasodilator. Okay, metoprolol, just throw it in with labetalol. It's a beta blocker. Okay, so there's just an assortment of medications that we can use. Okay, so what's hypertensive crisis? Blood pressure 180 systolic, 120 diastolic, either one of them. It's an umbrella term for two conditions, hypertensive urgency. So no symptoms, but we want to bring this blood pressure down. There's no end organ damage. Hypertensive emergency is the other one under this umbrella of hypertensive crisis, where we want to bring the blood pressure down now because there's end organ damage to the kidneys, the heart, the brain, somewhere in the body. Okay, so let's look at some antihypertensive medications to treat hypertension. Let's start on the right side of this slide, starting with diuretics. And really there's three groups of diuretics. And part of the grouping for this is just where they work in the kidney. And we'll also talk about which ones are the most powerful. Okay, so the first group is the thiazide diuretics. And they work on the distal convoluted tubule. And they basically stop reabsorption of sodium, potassium, chloride, and you lose those electrolytes into the urine along with water. Okay? Loop diuretics work on the loop of Henle. So if you think about it, the loop of Henle is where there's a lot of reabsorption of fluids. And it's closer to the glomerulus than the thiazide diuretic. So there's more fluid to block from being reabsorbed, and that's why they're more powerful. Okay, so loop diuretics, such as furosemide, have significantly more diuretic effect than hydrochlorothiazide, which is a thiazide diuretic. So you often flush more sodium, more potassium, more chloride, and more fluid with a loop diuretic. And that's why they're typically used more in congestive heart failure compared to hypertension. And thiazide diuretics are actually first-line medication for hypertension. Okay, spironolactone. Well, that's a potassium-sparing diuretic, meaning it's a diuretic that's going to inhibit the function of aldosterone, the hormone, on the kidney nephrons. Okay, so whether that's in the distal convoluted tubule or the collecting ducts, it's going to inhibit aldosterone. Well, if you inhibit aldosterone, you're going to block sodium from being absorbed into the body, so reabsorption, and you're going to block potassium from being secreted into the kidney nephrons. So it's potassium sparing, right? It's not going to drain you of potassium. So because sodium isn't reabsorbed and it stays in the nephron, water follows sodium and you get your diuretic effect without losing your potassium. Okay? And there's 2 or 3 different potassium sparing diuretics. They all basically work the same way. Okay? So remember, spironolactone is has a steroid ring as its molecule. So it can stimulate certain tissues in the body, and that's why you can get actually gynecomastia as a male, okay? Because it inhibits testosterone in the body. That's just how it works. And so it blocks testosterone a bit, so it lets the estrogen work a bit more in males, and it causes a bit of gynecomastia, some slightly enlarged breasts. We can also use spironolactone for acne because, again, it blocks testosterone a bit in the body. So we could add this to someone's acne medication if they had significant acne. Okay. Next group, calcium channel blockers. They can be used first line. Okay, so verapamil and diltiazem have 2 effects. They're vasodilators, just like all calcium channel blockers, but they also slow down the heart rate and reduce contractility of the heart. And that kind of is behaving like a beta blocker, but they're calcium channel blockers, okay? The one in the middle, amlodipine, and the one that's not there, nifedipine, they just cause vasodilation. They don't work on the heart at all. Okay, so if you're going to think of heart calcium channel blockers that slow it down and reduce contractility, diltiazem and verapamil. Angiotensin converting enzyme inhibitors. Well, they can be first line too, except in African Americans. So lisinopril, enalapril, they block, they're angiotensin converting enzyme inhibitors. So they block that enzyme, and that can cause an increase in bradykinins. And bradykinins is what gives people that cough. So people can complain of a slight tickle in their throat and a cough when they're on ACE inhibitors, and typically we have to stop them for that reason. Okay. What's the end result of someone being on an ACE inhibitor? Well, it's inhibition of production of angiotensin II. That's what we want to do. And when we block angiotensin II production, we get vasodilation, because angiotensin II is a very powerful vasoconstrictor. So we get vasodilation of the arterioles, and that lowers blood pressure. Okay. What side effects do you have to remember with ACE inhibitors? The cough that I mentioned due to increased bradykinins. So there's 2 other significant adverse effects. So because we block angiotensin II, I mentioned that angiotensin II is a powerful vasoconstrictor. That's true, but it also stimulates the adrenal gland to release aldosterone. So now, because we're blocking it, we're reducing production actually. We have less aldosterone secretion. That's going to cause sodium not to be reabsorbed and potassium to be retained in the body. And that's why you can get hyperkalemia with ACE inhibitors. Okay? And the last adverse effect that's significant is angioedema. So at any point while taking an ACE inhibitor, you can get angioedema, which is swollen lips, swollen tongue, and potentially a swollen airway. So that's an emergency. Okay? Hyperkalemia, angioedema, and a cough. Angiotensin II receptor antagonists. So they don't reduce the production of angiotensin II, they just block the action of angiotensin II. So valsartan, losartan, those are just angiotensin II receptor blockers. Okay, well, we're still going to get the same effect. You're going to get vasodilation around the body because you're blocking angiotensin II from getting to its receptor. You're going to get hyperkalemia because you're stopping angiotensin II from secreting aldosterone. So there's the hyperkalemia. You can still get angioedema, swollen tongue, swollen lips, airway issues, right? That's an emergency. The one you don't get is the cough because you didn't produce a byproduct called bradykinin with angiotensin II receptor antagonists. Okay, and that's why we switch people from ACE inhibitors if they have a cough to angiotensin II receptor antagonists. Okay, so both of these groups are first line in everyone except African Americans, because not only are they not as effective according to the studies, they also, African Americans get more angioedema with these drugs. So it's a higher risk medication. Okay. Next group, beta blockers, whichever one, there's probably about 15 of them, metoprolol, atenolol, labetalol. So beta blockers, what do? Well, they block the beta receptors in the sympathetic nervous system. So beta 1 receptors are mostly on the heart, so they block those, and when you block them, you get decreased contractility, decreased heart rate. They can also block the beta 2 receptors in the lungs, and that's why patients with asthma and COPD can have an exacerbation of their conditions when put on a beta blocker. They can get more wheezing, more shortness of breath because of the beta 2 blocking effects. Okay, and that's why we have beta 1 selective beta blockers that don't affect the beta 2 receptors in the lungs. So they're a bit safer, such as metoprolol. So if someone had asthma or COPD, we would likely be fine with metoprolol because they're more beta 1 specific. Okay. What else do we have to be concerned a bit about with beta blockers? Sorry. Well, what if your heart rate's less than 60? Well, we're not going to give someone a dose of a beta blocker if their heart rate's less than 60. Okay. What about a type 1 diabetic? If they're on beta blockers, they need to check their blood sugars more frequently to make sure they're not becoming hypoglycemic, because your sympathetic nervous system is responsible for detecting hypoglycemia. And if you're on a beta blocker, you won't know that you're becoming hypoglycemic, and that can get you into trouble, right? So checking the blood sugars more frequently if you're a type 1 diabetic and you're on beta blockers. So alpha-2 agonists, not a fan of this drug at all. So clonidine, it stimulates the alpha-2 receptors in the brain stem. And what does that do? Well, it reduces norepinephrine secretion in the body. Okay, so that doesn't make a lot of sense because it's actually stimulating a sympathetic receptor, but it has this opposite effect. And when you reduce norepinephrine, what happens? You get vasodilation, okay? That's going to reduce blood pressure. You get bradycardia because you're reducing norepinephrine in the body, so the parasympathetic system has more effect, and it reduces blood pressure. Unfortunately, it works in the brain, so you get a lot of side effects. So what kind of side effects does clonidine give people? Well, you get a dry mouth because you're blocking the sympathetic system by reducing norepinephrine. So the parasympathetic system gives you, well, actually, that's not a good reasoning for the dry mouth. Let me get back to that. So because it works in the brain, you typically often get fatigue with this drug. You can get headaches with this drug. You can get significant hypotension with this drug if it works too much in a person. And so we're very careful to tell people, do not stop your antihypertensive medications suddenly. You can get rebound hypertension. Okay. Another common side effect to clonidine is a dry mouth. Okay, so I'm not going to go into the pathophysiology of that, but it causes a dry mouth by reducing stimulation to the salivary glands. So that's a very common side effect of clonidine, having dry mouth and reduced secretions. Okay, so but this is not a first-line medication. So what are first-line medications? Diuretics, calcium channel blockers, ACE inhibitors, angiotensin II receptor blockers. All those are first line. Beta blockers aren't first line because you can get a lot of side effects to beta blockers. You can get fatigue, you can get depressive symptoms, you can get insomnia. So people get a lot of side effects to beta blockers. So they're not first line. They're still very effective. They're just not first line. Okay. Let's look to the left. So diuretics definitely have to monitor potassium in the serum, except for the potassium sparing, where you actually have to watch for hyperkalemia, elevated potassium. Okay. For the thiazide diuretics and the loop diuretics, we typically encourage a potassium-rich diet so that they don't become hypokalemic, right? And sometimes people have to be put on potassium supplements. Okay. Calcium channel blockers just happens to be a group where you should avoid grapefruit juice. So benzodiazepines is another group. The statins is another group for avoiding grapefruit juice, and now calcium channel blockers. ACE inhibitors, we watch out for that cough. We watch out for hyperkalemia. We watch out for angioedema, swollen lips, swollen tongue that can happen anytime while taking an ACE inhibitor. Angiotensin II receptor antagonists, well, same thing. You have to watch out for hyperkalemia. So you don't want them having a potassium-rich diet, right? Watch out for angioedema. So everything is the same in terms of adverse effects with ACE inhibitors and angiotensin receptor blockers, except for the cough. Okay. Beta blockers, we definitely don't stop these suddenly because they can get rebound hypertension, rebound tachycardia, right? I mentioned watching out for in type 1 diabetes for hypoglycemia, so they should monitor their blood sugars more frequently. It's not that the beta blockers cause hypoglycemia, it's just that the patient won't feel that their blood sugars are dropping while on a beta blocker. Okay, clonidine, so there it is, sedative effects, dry mouth, you can get headaches, fatigue. Okay, so not a great drug. Okay, so patient education. So depending on which medication the patient is on, keeping an eye on pulse rate, right? If you're on beta blocker, you want to know if your heart rate's less than 60 so that you can report that. Checking blood pressure. So there's many home monitoring devices that are really inexpensive and very accurate. Okay. So heart rate and blood pressure monitoring. And really the aim is to get the blood pressure, the systolic blood pressure, less than 140. Remember, diastolic blood pressure is also important. And if someone would like to try what's called a drug holiday, meaning they've been on an antihypertensive for a year or two, they've lost weight, they're exercising more, their blood pressure is really well controlled, say it's 120 on 70, but they've been taking these medications and they want to try tapering off them, well, that's very reasonable because they've had lifestyle changes, maybe they've quit smoking too, right? So the blood pressure may have come down by itself. So taking a drug holiday or tapering a patient off antihypertensives is always a good idea. Unfortunately, many patients stay on them for life. Okay? So what kind of symptoms can occur with antihypertensive medications? So first one is electrolyte imbalances. So if you're on a diuretic, for example, such as furosemide or hydrochlorothiazide, you can definitely get hypokalemic, right? And hypokalemia, so the body doesn't like when electrolytes start to change and get too low or too high. But hypokalemia can cause some cardiac arrhythmias as well. Not as dangerous as hyperkalemia. Okay, so if we think of electrolyte disturbances for diuretics, it's usually hypokalemia. Electrolyte disturbances with ACE inhibitors, spironolactone, angiotensin receptor blockers, that's hyperkalemia. Okay, again, very dangerous for the heart. It can lead to tachyarrhythmias, so very fast heart rates, such as ventricular tachycardia. Okay, so the heart does not like low or high potassium. What about heart failure? Well, some medications, such as calcium channel blockers, diltiazem and verapamil, well, they have negative inotropic effects and negative chronotropic effects on the heart. So we wouldn't typically put someone who has hypertension and heart failure on a calcium channel blocker because of that effect. And which two calcium channel blockers? Diltiazem and verapamil. Lightheadedness and dizziness is going to be purely from the blood pressure getting too low. So the patient comes back and says, when I stand up too quickly, I get super dizzy, or I'm just dizzy all the time, and that's because their blood pressure is changing significantly, right? Many patients need a combination of antihypertensives. In fact, it's quite uncommon to control hypertension very well with just one medication. I usually tell patients that you can expect a 10-point drop in your blood pressure with each antihypertensive. So it's not a huge change per blood pressure pill. Okay, so often people are on 2 or 3 antihypertensives. Now, patients also need regular appointments to monitor their blood pressure, to talk to them about lifestyle changes, quitting smoking, weight loss, exercise, their diet, and also adjusting of their medications. Often the first dose of the antihypertensive is not going to control their blood pressure, right? So dosing has to be adjusted, okay? The importance of adhering to medications is really important. So we tell people to really try and take their medications regularly. And if they miss a dose, okay, it's not the end of the world. Don't start double dosing. You just take the medication as soon as you realize you've missed it. If it's the next day, just start again with your new medication, or with today's dose. Okay, no double dosing. Remember, controlling blood pressure is a long-term issue. Okay, we want to control it in the long term to avoid strokes, heart attacks, renal failure, all those. Okay. All right, let's move on to the next slide. Okay, so let's just briefly talk about reversing adverse effects of antihypertensives. So really, it typically comes down to the fact that antihypertensives can lead to hypotension, right? They can lead to bradycardia, some of them, such as beta blockers or certain calcium channel blockers. So if we notice that someone has symptoms of hypotension, such as dizziness, falling over, well, we're going to check their blood pressure, and if it's too low, we're going to start tapering their medication away, right? So people often start antihypertensives and come back and say, I'm dizzy, I feel like falling over when I get up too fast, and that's hypotension, right? Decreased level of consciousness, I would actually say it's more dizziness and lightheadedness that people would come and complain of. And then we taper the medication downwards, right? Remember, we don't typically stop antihypertensives suddenly. If someone is really hypotensive, sure, we can give them IV fluids, and we typically give isotonic fluids such as normal saline or lactated ringers. We don't usually have to give anybody epinephrine for um, the the lowering of a blood pressure from an antihypertensive. We just usually stop the medication. So the only reason I can think of using epinephrine is if someone has an anaphylactic reaction to the antihypertensives. Okay? The same would go for vasopressors. So vasopressors are definitely used in conditions where there's hypotension. So when would we use them? Well, we could use norepinephrine in someone who is septic and we want to get their blood pressure up, right? Because norepinephrine very effectively causes vasoconstriction of the arterioles. We could use dopamine in someone with heart failure to try and increase the pumping of the heart because it has inotropic effects. It also increases the heart rate, so it has positive chronotropic effects. Okay, we don't usually need to do this for antihypertensives unless there's an overdose. So if someone comes in and takes a whole bottle of antihypertensives, well, sure, then we may have to give them a norepinephrine drip or dopamine to maintain their blood pressure. Okay, but in general, antihypertensives don't usually put you into shock unless you've massively overdosed on them. So epinephrine and vasopressors aren't usually needed. And epinephrine actually can be considered a vasopressor, so you can just throw that into vasopressors. Okay? Remember, vasopressors are exactly what they say. They cause increased pressure by vasoconstricting, vasopressors. So any of those can be vasopressors. Norepinephrine, that's a pure alpha-1 vasopressor. Dopamine, well, that stimulates the beta-1 receptors. It gets the heart rate pumping faster and harder. Okay? Oh, and epinephrine, of course, stimulates all the receptors. So you get tachycardia with epinephrine, you get increased contractility of the heart with epinephrine, and you get vasoconstriction with epinephrine because it stimulates alpha-1, beta-1, and beta-2. And alpha-2, but we don't usually talk about alpha-2 very much. Okay, so let's look at the complications of hypertension. And these are usually chronic complications. So it's not usually from 1 or 2 days of hypertension. It's from years and years of chronic hypertension. So we really try to control hypertension for the long term to prevent these organs from being injured. Okay, so the first one, kidney, right? So if the kidney has to see high blood pressure coming through its arterioles all the time, it gets damaged. And you get chronic, or you get gradual loss of nephrons, and that makes it difficult to regulate blood pressure and volume status, and you develop kidney failure because of the loss of nephrons from the chronic hypertension, right? So your BON is going to go up, and in particular, your creatinine is going to go up. Creatinine is a better marker of kidney function than BUN. BUN tends to go up and down with how much protein you ate, how little protein you ate, because it's just blood, urea, nitrogen. It's measuring the breakdown products of proteins and amino acids. Creatinine is more of a stable, steady marker of renal failure. Okay. What other complications can occur? Okay, now sometimes patients with hypertension can develop hypertensive crisis. So what's one of the most common causes of hypertensive crisis? Well, it's someone that has a history of hypertension and has stopped taking their medication, and their blood pressure significantly rises above 180 on 120. Okay, so remember, hypertensive crisis may be completely asymptomatic, such as hypertensive urgency, compared to a hypertensive emergency where you have end organ failure. And we know that from symptoms. So If someone comes in with chest pain, shortness of breath, in the setting of a hypertensive crisis, we'll call it a hypertensive emergency. Also, if they have neurologic symptoms, confusion, severe headache, that becomes an emergency. Acute renal failure with elevated blood pressure of 180 over 120. There's another hypertensive emergency, okay? Hemorrhagic strokes can occur with either chronic hypertension, which is typically the most common cause of a hemorrhagic stroke, right? But if someone has a sudden rise in their blood pressure from not taking their blood pressure medications, they can also develop a hemorrhagic stroke. Okay? Now remember the acronym BFAST, and that's an acronym for strokes, right? Any stroke. It doesn't have to be a hemorrhagic stroke. It could be an ischemic stroke. So balance. So patients that have symptoms where they're off balance, that can be a symptom of stroke. Eyes. So loss of vision, trouble seeing, loss of vision in one eye or both eyes, right? The face, so facial weakness or drooping on one side. What else? Arm, so weakness, unable to use the arm, or how about just numbness and loss of sensation of an arm? Okay, so a sensory symptom compared to a motor symptom. Okay, speech can be off. Right? So difficulty speaking, difficulty pronouncing, and last one is time, right? So it's important because we have a window with ischemic strokes to give TPA, and the window is around 4.5 hours currently. Okay, it used to be 3 hours, and then it's been stretched out to 4.5 hours. Okay. Okay, so what else can happen with chronic hypertension? So heart failure, that poor left ventricle is having to pump against a chronically elevated blood pressure. It starts to fail, right? And you get backup of fluid into the lungs. Atherosclerosis all over the body. So peripheral vascular disease. So atherosclerotic plaques blocking the arteries to the legs, occasionally the arms, that's less common. Okay, and you get peripheral arterial disease of the legs. Left ventricular hypertrophy, I've mentioned before, it's because of pumping of the left ventricle against chronic hypertension, and it causes thickening and enlargement of the left ventricle. And that can be an indication that someone is going to develop left ventricular heart failure years down the road because their left ventricle is enlarging. Okay, because they're chronically pumping against high blood pressures. Okay, and we can see left ventricular hypertrophy on ECGs. We won't do that today, though. Okay, so let's do the questions on hypertension, which are at the back of chapter 36. Okay. So number one, a nurse is screening a client for hypertension. The nurse should identify that which of the following actions by the client increase the risk for hypertension. So drinking 8 ounces of non-fat milk daily, that's not a risk for hypertension at all, right? So that shouldn't be an answer. Eating popcorn while at the theater. Well, popcorn has salt, right? Sodium. What's sodium going to do? It's going to make you drink. So patients with hypertension, with a history of hypertension, tend to be sensitive to intake of salt. It actually raises the blood pressure. So the average person that doesn't have hypertension, the kidneys can get rid of the salt very easily. So it doesn't tend to have that effect. But a patient with a history of hypertension, salt intake should be reduced so that it doesn't aggravate further increases in the blood pressure. So B would be an answer. Walking 1 mile daily at 12 minutes per mile pace. Okay, 12-minute mile. Okay, anyways, walking is not a risk factor for hypertension. In actual fact, exercise is typically improves hypertension. So that wouldn't be an answer. D, consuming 36 ounces of beer daily. Okay. Well, consuming beer is a risk factor for the development of hypertension. So heavy consumption of alcohol, whether it's beer or other types of alcohol, raises blood pressure. Okay, so that is a risk factor. So that's going to be an answer. Getting a massage once a week, so that's relaxation and stress management. No, that's not going to be an answer. So the answer is B and D here. Number 2, a nurse in an urgent care clinic is obtaining a history from a client who has type 2 diabetes and a recent diagnosis of hypertension. This is the second time in 2 weeks that the client experienced hypoglycemia. Which of the following client data should the nurse report to the provider? Takes psyllium, which is Metamucil, daily as a fiber laxative. No problem. That's totally fine. That doesn't drop your blood sugars. Okay. Drinks skim milk daily as a bedtime snack. That's not a problem either. Okay. Drinking skim milk, so low-fat milk at bedtime, that shouldn't cause hypoglycemia. C, takes metoprolol daily after meals. Okay, that's a bit of a concern. So metoprolol is a beta blocker. It's a cardioselective beta blocker, meaning it doesn't tend to cause those respiratory issues with asthmatics and COPD. So we use it, but we're still careful in asthmatics and COPD because they can block the beta 2 receptors and cause a bit of increased wheezing and shortness of breath. Okay, beta blockers cause fatigue. They can aggravate depression. But in this case, what's happening? Well, the patient isn't sensing the blood sugars going down because they're on a beta blocker, right? So diabetics that take a beta blocker, we have to be really careful. And they have to monitor their sugars more frequently to make sure that they're not becoming hypoglycemic. So the answer is going to be C. D, drinks grapefruit juice daily with breakfast. That's not usually an issue. I mean, grapefruit juice actually has a lot of sugar in it, so it's not going to cause hypoglycemia. In actual fact, it might cause hyperglycemia. Okay, so the answer is C. Number 3, a nurse is caring for a client who is admitted to the emergency room with a blood pressure of 266 on 147. Okay, that's very high. The client reports a headache and double vision. Okay, so they're not asymptomatic. So if it was just a blood pressure and no symptoms, we could call that a hypertensive urgency. But this is more than that. They have a headache plus double vision. That's concerning. This is more of a hypertensive emergency. The client states, I ran out of my diltiazem 3 days ago and I am unable to purchase more. Which of the following actions should the nurse take first? Okay, so that's a common reason for getting into trouble with hypertension and actually developing a hypertensive crisis, which, remember, is under the umbrella of, hypertensive crisis is either hypertensive urgency, no symptoms, no end organ damage, or hypertensive emergency, where there are symptoms and there is end organ damage. So let's look at the answers. Administer acetaminophen for the headache. That's not going to be a priority at all. Provide teaching regarding the importance of not abruptly stopping an antihypertensive. That is good advice, but not in the moment. Like right now, we have to deal with this high blood pressure. Obtain IV access and prepare to administer an IV antihypertensive. That's going to be the answer. This person is experiencing a hypertensive emergency. They need their blood pressure to be brought down in the next few hours. Okay. Call social services for a referral for financial assistance in obtaining a prescribed medication. That's not unreasonable, but that's not the priority at all. So the answer is C. This person needs treatment for hypertensive emergency. Number 4, a nurse is providing teaching for a client who has a new diagnosis of hypertension and a new prescription for spironolactone, 25 milligrams per day. Which of the following statements by the client indicates an understanding of the teaching? A, I should eat a lot of fruits and vegetables, especially bananas and potatoes. So bananas and potatoes have a lot of potassium. Spironolactone is a potassium-sparing diuretic. So it can cause hyperkalemia. And the way it does that is it inhibits the function of aldosterone. Aldosterone usually reabsorbs sodium and gets rid of potassium. So when you inhibit it, you will get rid of your sodium and have a diuretic effect, which is what it is. It's a diuretic. But you're going to retain your potassium in your bloodstream. So we don't want people on a diet that's high in potassium. Okay? So that would not be a correct answer. I will report any changes in heart rate to my provider. Not a big fan of that one. Spironolactone does not typically cause any changes in the heart rate. Let's look at the other ones. I should replace the salt shaker on my table with a salt substitute. Okay, so salt substitutes are usually replacing sodium, which is salt, NaCl, and they're often replacing it with potassium. Well, spironolactone is a potassium-sparing diuretic. We're not going to do that one for sure. D, I will decrease the dose of this medication when I no longer have headaches and facial redness. No, you can't predict what your blood pressure is based on symptoms. Okay? A lot of people do that. They say, well, I've got a headache, my blood pressure must be high. No, you can't gauge the symptoms and the blood pressure level. So let's go back to B. When you're on a blood pressure medication, you should be monitoring your blood pressure and heart rate at home. Okay? So this one is saying, I will report any changes in heart rate. I don't think that's really a fair answer. But in general, the advice is I will check my heart rate and blood pressure at home. So that's what they're trying to get at, and that is really the only answer there. So I don't like the answer, but that is the answer. So answer B. Number 5. A nurse is providing discharge teaching for a client who has a prescription for furosemide, a loop diuretic. Okay, so they're taking a loop diuretic. The nurse should instruct the client to take this medication at which of the following times of the day? So a loop diuretic is a powerful diuretic, and we can use it for hypertension. We don't very often. We typically use the thiazide diuretics, such as hydrochlorothiazide. That's a first-line antihypertensive. We typically use furosemide for taking fluid off of someone, having its diuretic effect for congestive heart failure or significant peripheral edema. But it can be used for hypertension. So when should you take a medication that is going to make you urinate a lot? Well, in the morning, right? As you take it later in the day, you're going to increase your chance of having to urinate through the night. So typically we suggest that patients take their diuretic in the morning. Okay, we definitely don't give it at bedtime or in the evening. So the choice becomes morning or immediately after lunch. Sometimes actually when we're giving a diuretic twice a day, we do give a dose in the morning and a dose at lunchtime. But if they're asking just for a single dose, it's going to be a morning dose. Okay, so let's talk about aneurysms before. I mentioned them earlier on in this module, and what's an aneurysm? It's a dilation of an artery, and it's typically from a weakness in the arterial wall, and it's often aggravated by chronic hypertension. So you can imagine there's already a bit of a weakness, and then on top of that, the inside of the artery has high blood pressure, which is going to make it dilate more and more over time. Okay, so the natural history of an aneurysm, whether we're talking about an aortic aneurysm, is gradual enlargement, right? It's going to get bigger and bigger and bigger, and that's why we follow them with either an ultrasound or a CAT scan, because we want to see if the abdominal aortic aneurysm is getting larger and larger, and if it is, it reaches a point where surgery has to be done. Okay, so in this image on the left, we're actually looking at the aorta, the abdominal aorta, and let's just say it splits into two arteries at the bottom, the iliac arteries, and they're going to head towards the legs to become the femoral artery. So what are risk factors for developing aneurysms? Okay, well, the first one is family history, right? Your genetics, which is going to determine the makeup of your arteries, and if you have a bit of weakened collagen in your arteries, well, it's probably a family history of it as well. Okay, so males are at higher risk for developing aneurysms. Atherosclerosis in the artery itself, so plaque formation damages the arterial wall and can lead to an aneurysm. Uncontrolled hypertension, so there it is. So high blood pressure constantly causing expansion of the arterial vessel. Tobacco use, why? Because it causes atherosclerosis and hypertension. Hyperlipidemia, why? Because it causes atherosclerosis. We'll just skip blunt force trauma. That's not important. Syphilis. So syphilis is a sexually transmitted disease, and syphilis can actually affect blood vessels, and it can weaken blood vessels, namely arteries, and cause aneurysms, whether it's in your abdomen or in your brain. Okay, and of course, increasing age. So someone who's getting older and older and older, well, that poor artery has endured decades of life, right? And it's starting to dilate and get an aneurysm. Okay, so the big ones here: atherosclerosis, hypertension, smoking, hyperlipidemia. Those are the big ones that lead to an aneurysm. And remember, what are we concerned about? A gradually increasing aneurysm, whether it's in your abdomen, your abdominal aorta, or in your brain, such as a berry aneurysm, hemorrhage. Okay, if someone's abdominal aneurysm ruptures and hemorrhages, there's a very good chance they won't even make it to the hospital. Okay, so it's hemorrhagic shock. If a berry aneurysm ruptures, well, they get a hemorrhagic stroke, and they can be devastating. Okay, so in the upcoming slides, we're going to talk about two conditions. So one is called, well, we've already referred to it, abdominal aortic aneurysm, which is a dilation of the aorta as it's spanning the abdominal cavity. Okay, so the aorta starts at the left ventricle, right? So the ascending aorta, and it becomes the arch of the aorta, and then it arches downwards, called the thoracic aorta, and once it goes through the diaphragm and into the abdomen, it's called the abdominal aorta. And this happens to be one place where people develop aneurysms. Okay, dilatation of the aorta, and if not careful, they'll get bigger and bigger and bigger. And usually we use a cutoff of around 5 centimeters for when the risk of rupture is significant and they need an operation to replace that segment of the aorta with either a graft. There's all kinds of options surgical options to repair an aortic aneurysm. Okay, so the last thing we want to see happen is a rupture. A ruptured aortic aneurysm is often deadly even before getting to the hospital. Okay, it's an absolute emergency. And usually they often come in with a blood pressure of 0. Aortic dissection is another condition that we're going to talk about where blood will dissect into the wall of the aorta. We don't really refer to it as an aneurysm, and I'm going to show you why on an upcoming slide. Okay, so think of it as its own condition. Okay, so let's look at the image first and get a good idea where you can develop aortic, abdominal aortic aneurysms. And it's in the segment that's below the chest, so the abdomen, and it's typically before the iliac arteries branch off. Okay, and it's the most common place for an aneurysm to develop. Okay, so that aorta there receives chronic pounding from the pulses from the heartbeat, and it can gradually dilate over years and years, and well, decades, and you start to develop an aortic aneurysm. Okay. I mentioned before that what are the main contributing factors? Chronic hypertension and just pounding away at that area, causing dilatation. Atherosclerosis, which weakens the arterial wall. There are certain connective tissue diseases that can weaken the arteries of the body, such as Marfan's disease, that causes the arterial wall to be weak and lead to an aneurysm. But I really think of it as chronic hypertension is the main risk factor, plus atherosclerosis. Okay, there's other ones, but those are the main ones. Okay, now an aortic aneurysm is asymptomatic. We often find these incidentally when we're doing a test for something else. So we order an ultrasound because someone's having abdominal pain for another reason, and we notice, oh, there's an abdominal aneurysm here. And once we see an abdominal aneurysm, then we follow it every year or every 6 months to see how it's enlarging gradually over time. Okay? We don't typically repair them unless they're rapidly enlarging over months to years, or they've reached a certain point where the risk of not repairing it becomes too high. Okay, so they're really asymptomatic. Other than if you were to feel the abdomen, you'd feel pulsations if you press someone's abdomen. Okay. So say someone comes in with an abdominal aneurysm that hasn't ruptured. Okay, no symptoms at all. If we were examining their abdomen for something else, we might feel a pulsating mass. Okay, that'll make us think of abdominal aneurysm. Nothing else. No other symptoms. Now let's say the aneurysm is rupturing. Okay, now you have severe abdominal pain, severe back pain because there's blood leaking out into the abdomen and to the back. So they come in with acute onset of severe back pain, severe abdominal pain, or flank pain, which is just to the side of the back. And of course, they can become hypotensive and lose consciousness from hypotension. Okay. So think of the abdominal pain or low back and abdominal pain as a rupturing aortic aneurysm, not one that's completely intact. About 5 years ago, I was seeing someone for abdominal pain related to something else, and when we did an ultrasound that day, the aneurysm was 10 centimeters. It was huge. So your normal aorta is usually about 2 to 2.5 centimeters. And we usually operate at around 5 centimeters. This person's aorta was 10 centimeters in diameter. So it was just massive. And it hadn't ruptured yet. Okay, so let's just briefly look at aneurysmal complications. So I mentioned before that aneurysms can gradually increase in size, and they will remain asymptomatic until finally the aneurysm ruptures. On the left here, we're looking at a saccular aneurysm, so that would be more in keeping with, say, a berry aneurysm in the brain. In the abdomen, it's more of a diffuse dilatation of the whole aorta. Okay, so um, like on the previous slide. Okay, so aneurysmal complications, well, they gradually enlarge. Well, that's still asymptomatic, except for a pulsation you might feel with an abdominal aneurysm. But then when they rupture, right? Sudden onset, abdominal pain, back pain, hypotensive because you're losing all your blood, and it results in a massive hemorrhage and often death. Okay, so that is why once we see an aneurysm in the aorta, in the abdominal aorta, then we follow them for enlargement and surgical procedures. Okay, so what do we do for a ruptured aneurysm? So a ruptured abdominal aneurysm, well, IV fluids. Often they need massive amounts of blood transfusions until we can get them to the operating room for immediate repair. Okay, so if they can survive to the operating room with IV fluids, blood transfusions, they may survive if they can get the surgical repair. Okay. The other issue that can occur with certain aneurysms, for example, you can get aneurysms in your popliteal artery behind your knee, and those happen to be more prone to thrombosis. And so the question is, well, why does a popliteal aneurysm cause thrombosis and an abdominal aneurysm typically results in dilatation and rupture? Well, it's just the nature of where the aneurysm is, okay? So with a thrombosis within an aneurysm, you get blockage of the artery. And so, for example, a popliteal aneurysm causing complete occlusion of the artery from due to thrombosis, well, you get your 6 Ps, right? Pulselessness, pale, poikilothermic, paralysis, paresthesia, all of those are occurring because you now have a blocked artery causing an ischemic leg. Okay? So those are the two complications of aneurysms. In general, rupture and hemorrhage is more common. So a berry aneurysm in the brain, well, that is going to rupture, or potentially rupture anyways. An abdominal aortic aneurysm, rupturing. A aneurysm of the popliteal artery in the leg, they're more prone to thrombosis. Okay, so let's look at the other condition called aortic dissection. So on the right there is an image of the aorta, and the aorta starts after the aortic valve, so coming from the left ventricle, and you can see the ascending aorta, the arch of the aorta, and then the descending aorta. Okay, so you can get an aortic dissection anywhere in the aorta. You can get it in the ascending, the arch, or the descending aorta. So what is an aortic dissection? Well, if you can imagine that the blood is flowing in the lumen of the artery, what happens if a little tear in the inner lining of the artery occurs and blood tracks into a false lumen? So it tracks and separates more and more that inner lining. Okay, so now you actually have what's called a false lumen. That blood's not going anywhere. It's just going to continually tear apart the layers of the aorta, and it's going to what's called dissect, right? And as it's doing that, it's actually narrowing the real lumen of the aorta. Okay, so that can occur anywhere. So really what's happening is the blood is dissecting behind the endothelial lining, and it's creating a false lumen, and it's continually dissecting because the aorta has high systemic blood pressure, right? So just going to keep on dissecting. What are some risk factors for aortic dissection? Well, definitely chronic hypertension. So you can imagine someone with very, very high blood pressure for years, and finally a little tear occurs in the intima, that endothelial lining, and they get an aortic dissection. Or a genetically inherited condition called Marfan syndrome. So it's autosomal dominant, and it's basically a soft tissue genetic disorder, and they have really stretchy tissues. And because of that, the aorta is stretchy and can tear, and they can get aortic dissections. Okay? Aortic dissections doesn't mean that the whole aorta has torn open and there's blood pouring out of the aorta. That's not common. It can happen, but it's not common. Aortic dissection is where there's blood separating the layers of the aorta. Okay. So what's the symptoms of an aortic dissection? Well, aortic dissections often occur in the chest, so the ascending or descending aorta, and you get this tearing, ripping, severe chest pain. So people come in and they say, I've got this terrible tearing chest pain that's going to my back, and it feels like there's something ripping inside. Okay. It can happen in the abdominal aorta, and the same symptoms, a tearing, ripping sensation in the abdomen and the lower back. Okay. And as this dissection continues, it's going to meet branches of the aorta, right? So if we look at the ascending aorta here, well, you can see that there's branches going off that are going to go to the arms, they're going to go to the brain. So as it dissects past those, it's going to block those. It's going to stop blood flow to different parts of the body. Okay, and that's where the symptoms are going to come in. Okay, so let's skip the first one in terms of hypotension. We'll come back to that one. Nausea, vomiting, faintness, apprehension, sweating. Well, that's basically your sympathetic nervous system turning on, saying there's something bad happening. And I'm turning on because I'm a warning signal to severe illnesses or severe diseases. Okay. Decreased peripheral pulses. Well, I just mentioned that as the dissection tears around branches of the aorta, they become occluded because the dissections affected the blood flow to them. So you can have loss of pulses to one arm. You could have, and that's a common one. So we'll often check pulses to each wrist. We'll check the radial pulses. And if one is absent in the setting of someone with chest pain that's ripping, well, we're really going to be concerned about an aortic dissection. So that's why you may lose a pulse, because the branch off the aorta gets knocked off and blocked. Okay, so reduced peripheral pulses can happen. Neurological deficits. Why? Well, the carotid artery is branching off the aorta. Okay, so if that becomes, if the dissection spreads to there, well, now you have basically a blockage of the carotid artery, and you can have stroke-like symptoms, right? Neurological deficits. Hypotension and tachycardia. So hypotension can occur if the dissection actually dissects right through the aortic wall. I mentioned that's not common. If that were to occur, you'd basically lose all your blood, just like in an aneurysm, and you'd become hypotensive. If you become hypotensive, your kidneys don't get any blood flow, and you become oligouria, so decreased urine production. Okay? So what are the main symptoms? Ripping chest pain, ripping back pain, feels like something's tearing. Activation of the sympathetic nervous system with sweating, nausea, vomiting, neurologic deficits because of the blockages of arteries, loss of a pulse in an arm can occur. Okay, as the dissection continues down the descending aorta, you can knock off other branches So you can get all kinds of symptoms because other branches that are of arteries that are coming off the aorta are getting blocked. Okay, so very serious condition. It can be deadly for sure. We control it with antihypertensive medications because these people are often hypertensive. And many aortic dissections require surgery, and it's a huge surgery to repair the part of the aorta that is dissecting. Okay, so let's do the questions on aneurysms, which is chapter 38, so at the back. Question number 1. A nurse in the emergency department is admitting a client who has a possible dissecting abdominal aortic aneurysm. Okay, so they have an aneurysm, which is a dilatation of an artery, commonly found in the abdominal aorta. You can also have cerebral aneurysms, which we call Berry aneurysms. You can have aneurysms in your popliteal artery, which is behind your knee. Okay, so, but a very common place is an abdominal aortic aneurysm. Okay, which of the following actions is the priority for this nurse? Well, if you're having a dissecting aortic aneurysm, it is a 3-alarm fire. You have to do something right now. This is an emergency. This person is going to die. They're going to rupture and go into hemorrhagic shock very quickly and then die. Okay, so administer pain medication is not the most important. Okay, it is important, but it's not the most important. Provide a warm environment. Now, this person is going to need IV fluids, massive blood transfusions, and get them to the operating room. So let's look at the only choice that's going to help here. Administer IV fluids as prescribed. So this question kind of doesn't give me the feeling of urgency, but this is an absolute emergency. Okay, so the answer is C here. D, initiate a 12-lead ECG. No. This person needs IV fluids, IV blood transfusions, and get them to the OR. So the answer is C. Number 2, a nurse is reviewing manifestations of thoracic aortic aneurysm. Okay, you can definitely get aneurysms in the thoracic aorta with a newly hired nurse. Which of the following findings should the nurse include in the discussion? Select all that apply. Okay, so thoracic aortic aneurysms can occur. They're not as common as abdominal aortic aneurysms, but they can definitely rupture as well, right? And when they rupture, the person bleeds out into their chest, right? So they're just not as a common, an overly common sight. So, which of the following findings should the nurse include in the discussion? Well, if you have an expanding aneurysm in your chest, could it make you cough? Absolutely. It might be putting pressure on a bronchial tube. It might be putting pressure on the lung, and it can irritate the lung and make you cough. Shortness of breath? Absolutely. Right? If it's putting pressure on the lungs or occluding a bronchial tube, it can definitely make you short of breath. C, upper chest pain. I'm going to leave that one for now because you could definitely get chest pain. D, diaphoresis. I actually think you can get diaphoresis with a thoracic aortic aneurysm. But it's not saying that it's rupturing here. So we'll just go back a bit here. Altered swallowing. Absolutely. If the thoracic aneurysm is compressing or pressing on the esophagus, you could definitely have difficulty swallowing. Okay, so A makes sense, B makes sense, E makes sense. Let's go back and look at C and D. So really what they're asking is which of the following findings should the nurse include, but they don't mention that it's actually either rupturing or dissecting. So C and D could definitely be symptoms of a dissecting thoracic aortic aneurysm. But it's not saying that. So because of that, they don't include them as the answer. I don't like this question. because they're not clear in the question of whether it's just asymptomatic and the person's living with it, and it's not very large, or it's actually potentially dissecting. So because it's not, they've excluded answers C and D. Okay, not a big fan of that one. C, a nurse is planning post-operative care for a client following a surgical placement of an endovascular stent graft to repair an aneurysm. Okay. Which of the following interventions should the nurse include in the plan of care? So endovascular means they're typically going to go into the groin, and they're going to, so as opposed to opening up the abdomen, moving the intestines out of the way, clamping the aorta, and then surgically removing the diseased aorta and replacing it with a graft, what they're doing is much simpler. So that is one option, the first one I just mentioned. The second one is to go into the femoral artery and put an endovascular graft in. That just you put it in through the femoral artery. Okay. So a nurse is planning post-operative care for a client following a surgical placement of an endovascular stent graft. Okay. Which of the following interventions should the nurse include in the plan of care? So assess pedal pulses. Okay. I don't really see an issue with this one. It should be correct, right? Because what causes peripheral pulses? Well, it's the blood flow from the aorta, right? So you should be checking the peripheral pulses. So that is correct. Okay, so assessing pedal pulses, for sure. B, monitor for an increase in pain below the graft site. Well, definitely, because if the graft occludes for some reason, suddenly you're going to have pain either in your pelvis or in your legs. Something is going to change because there's going to be reduced blood flow, and the patient's going to say, I have severe pain in my legs, for example. So yes. Okay, you always have to think of whenever an artery is changed, or there's surgery on an artery, or there's an injury to an artery, always have to think of the blood flow distal to the affected artery. Okay. C, maintain the client in a high Fowler's position. No, there's no need for that at all. Okay. You wouldn't want them fully sitting upright in bed. Monitor the femoral site for bleeding. Absolutely. That's where the insertion occurred, right? And the femoral artery is an artery. It's under high pressure. So you want to check for any bleeding at the site. You can actually have a complication of a large hematoma, so bleeding under the skin from the arterial procedure that was done. Okay, so D is an answer. Report hourly urine output of 60 mils. No, that's not really needed. Urine output of 60 mils. That's not really something that needs to occur. Okay, so the answer is A, B, and D. Let me just look at their reasoning for the urine output. Your urine output of 60 mils per hour is an expected finding. Which of the following interventions should the nurse include in the plan of care? Okay, I don't think you need to do that. So A, B, and D are the answers. Some of these select alls can be quite confusing, actually. Number 4, a nurse is teaching a client who has a new diagnosis of an aneurysm. Okay. The client asks the nurse to explain what causes an aneurysm to rupture. Which of the following statements should the nurse give? A, this can occur when the wall of an artery becomes thin and flexible. Okay? That's not really what causes an aneurysm to rupture. B, this can occur when there is turbulence in blood flow in the artery. Okay. Let's move on. It is due to abdominal enlargement. Okay, abdominal enlargement, that's an odd term. A abdominal enlargement makes me think of other parts in the abdomen that are distended, maybe a bowel obstruction or something else. It doesn't. That's not the cause. It is due to hypertension. So hypertension is definitely a long-term risk factor for developing an aneurysm, and it can cause the aneurysm to expand and then finally rupture. Okay, so the answer is D. It's a bit of the other answers are a bit odd. This can occur when there's turbulence in blood flow. Now that'll cause a murmur. So sometimes we'll put a stethoscope over somebody's abdomen and we'll hear a murmur there, and that's the turbulent blood flow that's occurring within the artery that has an aneurysm. Let me just look at A again though. And this can occur when the wall of an artery becomes thin and flexible. It's not really becoming flexible. It's actually enlarging, and the wall is the wall is becoming thinner, but it's not becoming more flexible. Okay, so that's not really true. And definitely D is the most correct answer because it is due to hypertension. Okay. Number 5. A nurse is admitting a client who has a suspected occlusion of a graft. Okay, so if they have an occlusion of a graft, basically what it's saying is you have an occlusion of an artery. Okay, that's bad news. Which of the following manifestations should the nurse expect? An increase in urine output? No, you shouldn't have an increase in urine output. If you have a blocked aortic aneurysm, so it's occluded, or the graft is occluded anyways, if it's above the level of the renal arteries, you could actually have a decreased urine output. Okay, so that's not an answer. Bounding pedal pulses, absolutely not. You may have absent pedal pulses because the aorta is blocked. Increase in abdominal girth. Okay, wow. Let's come back to that one. Lower extremities have irregularly shaped cyanotic areas. Okay. So I actually like D more than any other answer. Which of the following manifestations should a nurse suspect an occlusion of a graft of the abdominal aorta? Lower extremities have irregularly shaped cyanotic, so that's called modeling of the legs. If you have a blocked aorta, you'd have pale or bluish appearing legs. They'd be cyanotic. Okay, that's not really a fair question. I don't like that one. Let me just see their answers here. The client who has a graft embolism can have irregularly shaped cyanotic areas. Tenderness and decreased pulses due to the occlusion of blood flow from the thrombus. Okay, I don't know how they put increase in abdominal girth as the answer. I really think the answer, well, there's no good answer here, but I think the answer really should be that the lower extremity should be pale and cyanotic. Increase in abdominal girth means your abdomen is enlarged. Okay, so how would your abdomen be enlarged with a graft that's been put in? I don't think it would be. So I don't agree with answer 5. I'm going to tell you when I don't agree with the answers. And the only remotely accurate answer here is actually D. Okay. Okay, so let's continue on with strokes. I know strokes have been covered in the past in pathophysiology. We'll talk a bit more about strokes here. So basically strokes are permanent neurologic deficits, right? So there's been permanent death to a group of neurons somewhere in the brain. And usually strokes are from either ischemic damage, meaning a blocked blood vessel, a blocked artery that was feeding a certain area. So that'll be a thrombotic stroke. Or if the blood clot traveled from the heart and lodged into an artery, we'll call it an embolic stroke. Okay, so both of those are from a blocked artery. The other category is hemorrhagic stroke. So the artery ruptured and a section of the brain has died where that artery was feeding. Okay, so we'll talk about both. Okay, in the interest of time, I'm going to skip over this slide. I've already mentioned it, but basically these are just signs for the public to be aware of, to call 911 if they develop these symptoms or signs, right? So, I mean, the first one, balance. The other term for that is ataxia. I'm ataxic. I can't walk well anymore, and that's usually a cerebellar stroke. Your cerebellum is responsible for balance. So loss of balance with headaches. Well, that's concerning for a stroke. Or loss of balance and dizziness can be a stroke. Sudden loss of vision in one eye or in both eyes can be an indication of an ischemic stroke. Weakness of the face, usually unilateral, right? One-sided drooping. Weakness of an arm or a leg, again, unilateral. It shouldn't be bilateral. That would be very unusual for a stroke. Speech deficits, so difficulty producing words or difficulty with pronouncing words can both be signs of a stroke. Okay, I wasn't supposed to talk about it, sorry. Okay, so let's just look at the left and right-sided hemispheres. I know this will be a review for some of you. So your left cerebral hemisphere is where language occurs. Typically, in about 95% of us, it's the left cerebral hemisphere. So if that area is impacted, well, you might be aphasic. And aphasia means, well, you can have sensory aphasia, meaning difficulty understanding words, right? So difficulty understanding the speech of others. Or you can have a motor aphasia, meaning difficulty producing the words that will then become speech. So difficulty connecting the words together. That's motor aphasia. Okay, the next one, agnosia. Again, this all has to do with language. So this one is a loss of ability with recognition of objects or people or sounds or shapes, right? So you just don't recognize an assortment of environmental cues, okay? The next one is agraphia, and agraphia is the loss of the ability to write. Okay, that's, again, language, left hemisphere. Alexia is the loss of the ability to recognize words you once could read. So you just can't understand the written word anymore, okay? Mathematics is typically a left cerebral hemisphere function. Analytical thinking. Now, hemiplegia, hemiparesis, well, that's going to occur on the left or the right, right? So if you have a left cerebral hemisphere stroke, then you're going to have right, or potentially have right hemiplegia, which is paralysis of the right side of the body, or right hemiparesis, same thing, same term. Hemiplegia, hemiparesis, same term. Hemianopsia is a loss of a section of vision in both eyes. Okay, that's going to take more explaining, so hopefully we have a slide on that. So hemianopsia is, so you have two optic nerves, one coming from your left eye, one coming from your right eye, and they split at the optic chiasm, which is close to the pituitary gland, and part of the visual field from your right eye and part of the visual field from your left eye goes to your left hemisphere, and the exact same occurs with the right cerebral hemisphere. Part of the vision in your left eye and part of the vision in your right eye goes to the right hemisphere. So it just depends on where the nerves have been affected that we're going to the occipital cortex, which is right at the back of the brain. Okay. Now let's look at the right cerebral hemisphere. So visual awareness is a right cerebral hemisphere function. There's that hemianopsia again, because again, the optic nerves split and went to each cerebral hemisphere. So you can have hemianopsia with a left cerebral hemisphere stroke or a right cerebral hemisphere stroke. Spatial awareness, depth perception is a right cerebral hemisphere function. Neglect, so proprioception is knowing where we are in space. So right now you know where your feet are, where your hands are, where your head is. And if you have a right cerebral hemisphere stroke, you may have neglect, meaning you're not really aware of where your body is in space on that side. So with a right cerebral hemisphere stroke, you might have a left-sided neglect. Okay. Hemiplegia, hemiparesis, it'll be the left side of the body because we're talking about the right cerebral hemisphere. Okay. Okay, so let's talk about stroke types. So the first one is not a stroke, transient ischemic attack. So it's almost, we used to call them mini strokes, but that term isn't accurate either, so we've stopped doing that. And then we used to call it a warning stroke. Well, that's not really accurate either, although if you have a TIA, it is a warning that you may get a stroke. So a TIA occurs from a little plaque or a little broken off bit within the blood vessel that travels to a certain part of the brain, blocks the artery temporarily, and gives you symptoms. So let's say you have a TIA to the part of your brain. So you have a little plaque that breaks off, travels in the artery to the part of the brain that supplies function to your right face. So suddenly you have loss of motor function to your right face. So you have a droopy face and difficulty speaking, and typically it resolves in 30 to 60 minutes. Some of them resolve within minutes, a few minutes, okay? There's no permanent neurological damage, none at all, okay? But what it's an indication of is you have little bits of atherosclerosis that are breaking off and traveling to your brain, so you're at risk for developing ischemic strokes, okay? So if someone has a TIA, we definitely investigate them and look for any areas that are correctable. So we'll do an echocardiogram, looking to see if there's any blood clots in their lungs that are traveling to the brain. We'll do an ECG to make sure that they don't have atrial fibrillation that can predispose them to throwing off clots. We'll do an ultrasound, a Doppler ultrasound of the carotid artery to see if there's a stenosis and a blockage there that's throwing off little atherosclerotic clots. Okay, because those are reversible areas that we can do something about. Okay. All right, what's an ischemic stroke? Well, remember, there's two types of ischemic strokes. There's a thrombotic stroke where an artery within the brain just blocks off from atherosclerosis and thrombosis, blocks, and then a part of the brain dies. But under ischemic stroke, there's also embolic stroke. So a piece has traveled from, say, the heart chamber in atrial fibrillation, traveled to an artery in the brain and blocked it. So ischemic strokes can be thrombotic or embolic. Okay. And finally, hemorrhagic stroke. So an artery within the brain has ruptured, and the section of the brain that artery was feeding is no longer being fed with blood, and it dies. Okay, so ischemic strokes, two types, embolic and thrombotic. And hemorrhagic stroke, what's the most common cause of hemorrhagic stroke? Chronic hypertension and the possibility of a weakened artery, say from a Berry aneurysm. Okay. So if we look at the image on the right, hemorrhagic stroke, you can see that blood that's leaking out from the vessel, compared to an ischemic stroke where there's no blood supply, there's no leakage either, there's just a complete blockage there. and then a section of the brain is then going to die. Okay, so let's look at TIAs in a bit more detail. So let's say that you have some atherosclerosis of the internal carotid artery. Okay, so the internal carotid artery is the artery that goes through the skull and into the brain. Okay, external carotid artery takes a different route. So say you have some plaque and some atherosclerosis on the inside of the carotid artery, and a piece breaks off. A tiny little piece breaks off and travels to a cerebral blood vessel and temporarily occludes it. That's what causes a TIA. It's a temporary occlusion of a small artery in the brain. And it almost always resolves within minutes. Okay, it's even uncommon for it to last an hour. Usually it's minutes. And it gives you the identical symptoms of a stroke, right? Because there's no blood flow to that part of the brain. So you're going to have neurologic symptoms that mimic a stroke. The difference is that these disappear within minutes to an hour. Okay? Now, TIAs are warnings that this patient may develop a full-blown stroke. If a larger piece breaks off and travels to the brain and they get a full-blown stroke with neurological damage and death, then that's a stroke, right? So we take TIAs more seriously now because they're a warning that a stroke may be occurring in the future. Okay, so it's temporary ischemia from a little piece of plaque, and luckily the body is able to clear it and break it up, and they get resolution of symptoms and return to normal. Now, if this happens to come from a carotid artery and we notice it on a Doppler ultrasound of the neck, well, that's treatable with a carotid endarterectomy, where they basically do a surgery and remove the diseased part of the carotid artery and remove all the atherosclerosis so that the artery is clear to allow blood flow to the brain. If it's from atrial fibrillation that's thrown off a clot and traveled to the brain and caused a TIA instead of a stroke, well, we can try and treat atrial fibrillation by trying to convert it to a normal rhythm and also putting patients on anticoagulants to prevent the formation of clots within the cardiac chambers. Okay? Okay, so ischemic strokes. So as I mentioned before, ischemic strokes is basically a blockage of an artery that supplies the brain. And the blockage can come from thrombosis within the artery itself, or the blockage can come from an embolus that's traveled from the heart or traveled from the internal carotid artery and blocked an artery. Okay, blocked a cerebral artery, sorry. So ischemic strokes, two types, embolic, thrombotic. Okay, and these make up about 85% of strokes. The other 15% being hemorrhagic strokes. Okay, so ischemic strokes are much more common than hemorrhagic strokes. Okay, so let's look at a medication that can be used for ischemic stroke, and it's called TPA, so tissue plasminogen activator. And, you know, in quotations, we call it the clot buster, right? So it turns plasminogen into plasmin, and what does plasmin do in the bloodstream? Breaks down clots, okay? So this drug can be given intravenously for ischemic strokes, right? And we use thrombolytics also for STEMIs, ST elevation myocardial infarctions, right? So for a STEMI, we have two options. We can either give them a thrombolytic, and it works the same way as TPA, or direct to the cath lab to have a cardiac catheterization and try and open up the blocked coronary artery. In ischemic strokes, if they come in a certain time frame, typically, well, it's a moving target, but typically We only give this medication up to 4.5 hours. Some centers have moved out to 6 hours, but a lot of centers are still at up to 4.5 hours. It used to be only 3 hours, so they're slowly moving it out a bit more. Okay, so it breaks down clots. So in ischemic strokes, remember, an ischemic stroke is either thrombotic in an artery or embolic and blocking the artery, and we want to open up that artery. So what are the eligibility criteria for giving someone TPA when they arrive with a stroke? Well, the first thing we need to do is determine that it's an ischemic stroke, and that's with an immediate CAT scan. Okay, so we need a CAT scan to rule out a hemorrhagic stroke, because this drug would cause massive hemorrhage if we gave it to a hemorrhagic stroke. So that would be an absolute contraindication. Okay, so we're going to get a CAT scan as fast as possible. We're going to do some routine blood work, and I'll explain why in a minute. And if we determine that it's an ischemic stroke and it's less than 4.5 to 6 hours, they may qualify for tissue plasminogen activator, TPA. Okay. So TPA is usually given IV. There are some centers, some specialized centers that go into the artery, a cerebral artery, and squirt TPA right into the blocked artery to try and break up the clot directly with TPA arriving there instead of just intravenously and going all over the body. Okay, so that's much more targeted compared to just a systemic infusion of TPA. So let's look at the eligibility criteria. So you have to be over 18 years old. You need a diagnosis of an ischemic stroke. Okay, you can't have anything else. You can't have a migraine. You can't have a hemorrhagic stroke. It's got to be an ischemic stroke. The time of onset needs to be less than 6 hours, because we know that thrombolytics really don't work beyond 6 hours. In some centers, as I said, only use it up to 4.5 hours. Your blood pressure has to be less than 185 over 110. Again, it's a risk of bleeding if you have a very high blood pressure and you give TPA. This is all about preventing bleeding. So not giving it if there's risks, if there's increased risks of bleeding. Okay, next one. We don't give it in minor strokes, and we don't give it in strokes that are actually resolving on their own. Okay. We try not to give it in patients that have had a seizure at the start of a stroke. That may indicate that there's been some blood that's irritating the brain and led to a seizure. We don't give it if someone is on warfarin and their INR is greater than 1.7. And if you remember, a normal INR while on warfarin is 2 to 3, right? So that would knock out people from receiving this drug if their INR was greater than 1.7. They shouldn't be receiving heparin, because that's another anticoagulant. They should have a platelet count greater than 100,000. They should have a glucose greater than 50. Why is that? Well, hypoglycemia can mimic a lot of stroke symptoms. So one of the first tests that we get while getting the CAT scan as soon as possible is a CBC, looking for the platelet count, and a blood sugar, looking for that glucose, to make sure that they don't have stroke mimics, that they don't have symptoms from hypoglycemia. They should not have any intracranial hemorrhaging. I mentioned that before. They shouldn't have brain cancers or any abnormal blood vessels in the brain, including aneurysms, because they're all at risk of bleeding. They shouldn't have any major surgery within the past 14 days. They should not have had any recent stroke, head injuries, or intracranial surgery within 3 months. No gastrointestinal bleeding within 3 weeks, and absolutely no pregnancy. Okay, so those are eligibility criteria. There's definitely some other absolute contraindications, but this is a good list to start with for sure. Okay, So while they're getting a CAT scan, while they're getting a bit of blood work, all of this is really rushed. A diagnosis of ischemic stroke is made, and then the discussion centers around the pros and cons of receiving thrombolytic therapy. The patient will definitely be told that there's a risk of massive bleeding, and all of these criteria will be quickly assessed prior to giving TPA. Okay, bleeding into the brain, well, that's a hemorrhagic stroke, right? So a rupture of a cerebral artery is a hemorrhagic stroke. This, of course, this can definitely increase intracerebral pressure as blood is exiting the ruptured artery. And it damages neural tissue, and it causes neural death, right? So what's the most common cause? Chronic hypertension. You can also have certain abnormal arteries that are predisposed to rupturing, such as an artery with a Berry aneurysm, or an artery in the brain with what's called an arteriovenous malformation, where the arteries and veins are malformed and they're very fragile and they bleed, and patients get hemorrhagic strokes. In fact, AV malformations are a common cause of strokes in young people. Okay. Remember, hemorrhagic strokes only make up about 15% of total strokes. 85% are ischemic strokes. Okay, so let's look at some stroke risk factors that are listed here, and we'll see what kind of strokes occur with them. Okay, so cerebral aneurysm, so what we call a Berry aneurysm. These little outpouchings that occur in cerebral arteries, and they're tiny little aneurysms that can rupture. So a cerebral aneurysm can result in a hemorrhagic stroke. Arteriovenous malformations are malformed arteries and veins. They're congenital, so they occur at birth, and it's a common cause of strokes in children and adolescents, right? So they cause hemorrhagic strokes because they're fragile vessels that break open. Diabetes, that's a risk factor for atherosclerosis. So we're going to be talking about ischemic strokes with diabetes. Diabetes causes damage to arteries, it causes hypertension, it leads to renal failure. So it's a risk factor for atherosclerosis that leads to ischemic strokes. Obesity, well, obesity can cause hypertension, so it's a risk factor for hemorrhagic strokes, but obesity is also a risk factor for hyperlipidemia, hypercholesterolemia, diabetes. So those are all risk factors for atherosclerosis, which then result in ischemic strokes, right? Hypertension. Well, hypertension causes hemorrhagic strokes, but hypertension is a risk factor for atherosclerosis too, right? And so it can lead to ischemic strokes as well. Well, atherosclerosis is just a condition, so the next topic is atherosclerosis. So we've been talking about risk factors for strokes. So if somebody has diffuse atherosclerosis in their arteries, definitely a risk factor for blocking up an artery in the brain, causing a stroke. Hyperlipidemia, absolutely. So hyperlipidemia / hypercholesterolemia, that's going to result in atherosclerosis, causing ischemic strokes. Hypercoagulability states. So there's certain diseases that lead to having really hypercoagulable blood, and that's going to make the blood clot in arteries and cause an ischemic stroke. Atrial fibrillation. Well, atrial fibrillation is a very irregular rhythm of the heart. The atria actually aren't contracting in sequence and regularly, so you get clots forming in the atrium, the left or the right atrium. When they form in the left atrium, they break off, travel to the left ventricle, and then get pumped out to different parts of the body, including the brain. If the clot goes to the brain, it causes a embolic stroke. Oral contraceptives, I've mentioned before, cause thickening of the blood, so they cause hypercoagulability, and they can lead to ischemic strokes. Smoking causes atherosclerosis, and atherosclerosis causes ischemic strokes. Cocaine use causes severe hypertension, so it can cause hemorrhagic strokes, and because it causes hypertension, it damages the arterial wall, and it can lead to atherosclerosis, which causes ischemic strokes. So, there's there's a lot of variability. A lot of things that cause hemorrhagic strokes can also cause ischemic strokes. Okay. Okay. So on the right here, stroke risk scorecard. So this is really helpful, right? Blood pressure. Think of these as all the risks, right? Blood pressure, atrial fibrillation, smoking, cholesterol, diabetes, physical activity, weight, family history of stroke. So you can actually get a bit of a risk score that you can provide to someone and say, you know what, you're at really low risk of developing a stroke in the next 5 years or 10 years, because look at the lack of risk factors that you have. Or on the alternative, you could have someone who has major risk factors for developing a stroke. Okay. And remember that this stroke risk scorecard is for ischemic and hemorrhagic. So, for example, blood pressure there, well, blood pressure can cause hemorrhagic strokes, but also it causes atherosclerosis, which causes ischemic strokes. Atrial fibrillation, embolic strokes. Okay, so they're kind of combining a whole bunch of risk factors together to get an overall risk for either hemorrhagic or ischemic strokes. Okay, so let's just talk briefly about stroke assessment. So under history, when someone comes in, and let's assume that they're having an ischemic stroke, we really want to know when was the last time you were normal, right? Because that gives us a time frame of how long the ischemic stroke has been for. And because TPA is really determined whether it's going to be administered or not on time frames, right? So if the hospital has a time frame of 4.5 hours, well, if it's over that, they don't give it, right? So, for example, if someone wakes up in the morning and they have hemiplegia, say the right side of their body is completely paralyzed, well, nobody has any idea of how long it's been because they went to bed, say, at 10 o'clock at night. So they're not a candidate for TPA because of the length of time and the unknown time of when the stroke occurred, right? We're also going to ask about TIAs. Have you been having any neurological symptoms that have lasted a few minutes and then resolved? Those are TIAs, so patients often have TIAs prior to having an ischemic stroke. Okay, so remember, if someone comes in with a stroke, what we really want to do is get a CAT scan, get a CBC and blood sugar right away, right? CBC to look at the platelet count, blood sugar to look to see if they're hypoglycemic. We cannot give TPA if someone's hypoglycemic because that could be the cause of their symptoms. So we'll give them sugar first to get their blood sugar up to see if their symptoms resolve. So everything is done really quickly because time is of the essence, right? After history, there will be a very rapid neurologic assessment. So the first one in someone with an acute stroke is going to be airway. Are they able to breathe on their own? Cardiovascular stability, so blood pressure, heart rate, right? And then a gross neurological exam. Can you move your arms? Can you move your legs? Can you smile for me? Can you close your eyes? Let's look at the pupils. Are they reactive? And level of consciousness, right? So you can look at someone and really quickly determine their level of consciousness, Can they move their arms? Can they move their legs and their pupils? That's a gross neurological exam. Okay. And really, the goal of TPA is to, and the goal of treating strokes is minimize how much brain tissue dies. And that's why in an ischemic stroke, um, TPA is used to try and minimize the amount of neuron death. Okay? There's a lot of debate about TPA for many, many years. There's a lot of studies that show that it's not very effective. And then there's some studies that show that, yeah, there's some benefit and that's all we have to offer. Okay, so it just depends on what you look at. So there's a score that's used called the NIH stroke scale score, NIHSS score, and it just scores the severity of the stroke. So for example, 0 is don't have any symptoms of stroke. And then the higher your NIH stroke scale, the more severe the stroke is. Okay, so someone with a really, really minor stroke with a score of 1 to 4 really isn't going to be a candidate for TPA. The risks outweigh the benefit. Someone who arrives early and has an NIH stroke scale score of 30, well, okay, that's pretty severe, right? They have significant neurologic deficits, and if we could even improve them a bit, it might be to their benefit. Okay, so everybody will get a stroke scale score before receiving TPA. And again, this is really fast, right? So CAT scan, super fast. Blood sugar, some blood work. We want to do an NIH stroke scale, and we want to assess the patient for TPA indications and contraindications. But all of this can be done really, really fast. Okay, so I'm going to skip this slide. This is a video on the National Institute of Health stroke scale. I'll leave it to you to watch. Remember what this scale is for. It's to grade the severity of the stroke. 0 meaning no stroke symptoms, and the higher the NIHSS score, the worse the stroke. Okay, so let's look at some diagnostic tests for stroke. And the most important when someone appears to the hospital with stroke-like symptoms is CAT scan. CAT scan is going to help us distinguish between hemorrhagic and ischemic stroke, and we really want to know that. Hemorrhagic, totally different treatments compared to an ischemic stroke. In hemorrhagic stroke, sure, we'll control blood pressure, we'll remove them from their blood thinners, we may even reverse their blood thinner effects. We may consult a neurosurgeon if it's a massive hemorrhagic stroke and they may be able to remove some of it. In an ischemic stroke, it comes down to, is there anything that we can offer, and can we offer TPA? Okay, so that's why we do a CAT scan really quickly. Don't forget about the blood sugar, because we need that blood sugar to determine, to prove that they're not hypoglycemic, and that's what's causing their symptoms. Okay, so CAT scan, why? Hemorrhagic versus ischemic stroke. Okay. Now, sometimes a CAT scan will not show the ischemic stroke for about 2 to 3 days. Okay, but there's some changes on CAT scan that the radiologist can still identify and determine that there's been an ischemic stroke. So there's often some edema in the brain, and they can see some very mild changes that are occurring within the brain that help them determine that yes, there's likely an ischemic stroke occurring. Okay. Let's just change topics here a bit. So the Glasgow Coma Scale is not a diagnostic test for stroke. Okay, that was the CAT scan. The Glasgow Coma Scale is to assess someone's level of consciousness in any scenario. So it could be someone who's overdosed on morphine. It could be someone who's overdosed on a benzodiazepine or had a head injury. Anytime we want to assess someone's level of consciousness, we can do a Glasgow Coma Scale. and it consists of 3 different parts. What's their eye response? What's their verbal response? And what's their motor response? Okay, and it's graded out of 15. So the lowest score you can get by just showing up to the hospital is a 3. You cannot get lower than a 3. In fact, someone who's dead has a Glasgow Coma scale of 3. Okay, so let's just look. What gives you a maximum score of 15? Well, eye opening. So when I look at you and you open your eyes spontaneously without me doing anything, you get a 4. Okay, so the highest you can get for eye opening is a 4. The best verbal response. Well, the best verbal response is that you're fully oriented. So you know where you are, you know who you are, you know what time it is. You get a 5 for that. And the best motor response. So if I ask you, can you shake my hand? Can you move your right leg? So you obey commands and you perform the motor response, that's a 6. And the total will be a 15. Okay? And then it just goes down from there, depending on which part is affected. The eye opening, the verbal response is down, or the motor response is down. So this is a very useful tool that you should know, because we use this to follow people, to follow patients' level of consciousness. And if the Glasgow Coma scale is descending, it's going downwards, that's bad. That's a worsening prognosis. And often it means that the patient's going to need to be intubated to protect their airway. An improving Glasgow Coma scale, so the scale is going upwards, is a good sign. Our treatments are positively affecting the patient. Okay, and the Glasgow Coma scale allows us to communicate with other healthcare professionals. So if I say someone has a GCS of 10, the other healthcare professional I'm talking to will understand what a 10 is, or what an 8 is, or what a 15 is. Okay, so a very useful tool. You should know that it's for level of consciousness, and you should know how to calculate a Glasgow Coma scale. Okay, so let's look at some nursing interventions for stroke patients. And really the goal with acute stroke is we want to prevent secondary injury. So what does that mean, right? So someone comes in with a stroke. Okay, there's not much we can do about the stroke that's already occurred, but we want to prevent anything else that's going to cause the stroke to be even worse. Okay, so how do we do that? Well, let's look at the assessment at the top left. So we're going to do frequent vital signs, so every 1 hour. Why do we do that? Well, we want to make sure that they're not hypotensive. There's nothing worse for the brain than not getting fed with oxygen and nutrients. So we want to make sure that they're not hypotensive at all. Okay? We want to make sure that their oxygenation is good in their bloodstream. Right? And if it's not good, we'll give them oxygen. Right? So we're constantly assessing the vital signs, looking for hypotension or poor oxygen saturations. Cardiac assessment and monitoring, and ECG. We want to see, is this person in atrial fibrillation, right? Do they need further testing on their heart? Because maybe they have atrial fibrillation and they have a blood clot in one of their chambers of their heart. Monitoring of level of consciousness. If you have a stroke and your Glasgow Coma scale is gradually descending because you have elevated intracerebral pressure, well, that's a problem. If you had, when you came in, you had a GCS of 15, and then it went to 13, and then 11, and then 9, and so on down, well, that's an indication that your neurologic status is worsening, probably from cerebral edema or bleeding, and you're likely going to require mechanical ventilation and intubation, right? So monitoring level of consciousness, really important. Assisting the client or the patient with communication skills, right? Some patients are unable to communicate any longer because they have aphasia, the inability to either understand what you're saying to them, that's a sensory aphasia, or a motor aphasia, meaning they're unable to communicate and talk to you. Very frustrating. Okay. Positioning the bed. So the head of the bed should be upright, around 30 degrees. Doesn't have to be upright in high Fowlers, but upright a bit to prevent aspiration. Okay, nothing worse than getting a pneumonia after you've had a stroke. Positioning in the midline position and not twisted in the bed. Okay, that makes sense. Elevating any affected extremities. Why? Because they're going to become edematous, right? If you're not moving your arm or your leg, you're not getting any muscle contractions because it's paralyzed, you're going to get edema forming in the arm or the leg. So elevation of the affected extremity. Okay. What else can we do in terms of, well, what about support? So encouraging sitting upright, taking deep breaths and coughing, and that's going to avoid atelectasis. That's going to avoid pneumonias that may set in, right? Helping the client with activities of daily living, and that might be feeding themselves, washing themselves, all kinds of activities of daily living that they'll need support with. And with strokes, you can develop all kinds of emotional changes. Often patients will become depressed after a stroke. They can develop anxiety after a stroke, okay? And they can be very frustrated after a stroke because often they can't speak, okay? Or they can't, their life has completely changed, okay? In terms of safety, seizure precautions, remember stroke is an injury to the brain, so you're at risk for seizures. Any injury to the brain puts you at risk for a seizure, whether it's a head injury as a child or a stroke at any age. Okay. Preventing complications of being immobile, so skin breakdown and ulcers, DVTs, right? So need to prevent these complications. Having someone lying in a bed is just, they're a sitting duck for skin breakdown over pressure sites like their hips, their ischial tuberosity in their buttocks, their heels. They're sitting ducks for deep vein thromboses in their legs. Then of course that could turn into a pulmonary embolus, right? Maintaining a safe environment to reduce falls. So you wouldn't want floor mats and carpets all over the place and altering the furniture in the room all the time, just to make it difficult, for them to maneuver around in their living space, right? They're going to require rest periods because they're exerting a lot of energy with the neurologic function that they have remaining, okay? And definitely assisting in safe feeding because they're at risk for aspiration, right? And typically someone who's had a stroke gets a swallowing assessment by a speech therapist. And some of the nurses are actually trained in that as well. And it's really a swallowing assessment to make sure that they're able to swallow food and not aspirate it. Okay. So unfortunately, patients with strokes are often left with dysphagia, which is difficulty swallowing. Okay. So now I'll just throw out another term for you: odynophagia. So odynophagia is painful swallowing. And strokes don't usually cause that. Other conditions of the esophagus can give you painful swallowing. But dysphagia is difficulty swallowing, and that is a very common side effect or effect of having had a stroke. Okay, and the issue with dysphagia is not only a feeding issue in terms of getting food into your stomach for nutrition, it's also the risk of aspirating that food while swallowing and it landing in your lungs. And if you get foreign material in your lungs, you're at risk for developing significant pneumonias, right? So that's why aspiration is such a big deal. Not only can they become hypoxic because of breathing difficulties, but it sets them up for developing pneumonias. So what can we do in terms of assisting with safe feeding? Well, eating upright for sure. Patients should never eat supine or in low Fowlers. That wouldn't be a good way to eat if you've had a stroke. Flexing chin to chest. That can help with the swallowing of the bolus of food, right? So in terms of flexing their neck forward to their chest. Placing food in the back and on the unaffected side can help a bit. So helping the food get to the back of the throat instead of putting it right on the anterior part of the mouth. And on the unaffected side, or the unaffected side of the body that hasn't sustained a stroke. Okay, definitely always having suction prepared because you never know when someone's going to choke following a stroke. Not having the patient multitask, right? A distraction-free environment so they can focus on the eating and swallowing, which has become an effort for them. Okay, discussing with the dietitian to ensure proper caloric intake. That's really important because I just mentioned that swallowing difficulties can certainly occur. Consulting with a speech therapist to decide on the textures. So liquids, can they drink thin liquids? Does it have to be thickened liquids, which is kind of unfortunate. Can you imagine drinking thickened liquids for the rest of your life? That's difficult, right? Foods, do they need to be pureed? Do they need to be altered in some way so that it reduces the risk of aspiration? So soft food diet, or can they have a regular food diet? So speech consultant can help with that, okay? They often do the swallowing assessment. Okay, so dietitian consultation, speech therapist consultation to discuss textures and what type of foods they're able to consume in terms of liquids and foods. Okay, what about treatments for stroke patients in terms of medications? Well, let's just start with anticoagulants, and let's make this clear. So, if someone's had a hemorrhagic stroke, well, they don't need anticoagulants now or later. If someone's had a thrombotic stroke, meaning just an artery in their brain clotted up, they don't usually need an anticoagulant. We treat those patients with antiplatelets, such as aspirin or clopidogrel, which is Plavix. Okay? Who needs anticoagulants? Well, typically that's going to be a patient who has had an embolic stroke from atrial fibrillation. So they formed a clot in the chamber of their heart from atrial fibrillation, and it embolized to the brain, causing an ischemic stroke. Those patients need to go on long-term anticoagulation with warfarin or one of the other oral anticoagulants, such as rivaroxaban or apixaban. Okay. In the short term, sure, IV heparin can be used in hospital. Low molecular weight heparin, such as enoxaparin, can be used, but typically they're going home on an oral anticoagulant, such as warfarin or one of the others I mentioned. Okay, and that's for atrial fibrillation. So in general, if it's not atrial fibrillation, then we use antiplatelet medications such as aspirin and clopidogrel to prevent further strokes in someone who's had an ischemic stroke. Okay, acutely, we can use thrombolytics, right? TPA, to try and dissolve the acute stroke. And that's typically within 6 hours of the onset of the stroke. Okay, so thrombolytics is only for the acute period of within 6 hours of developing a stroke. Anticoagulants for atrial fibrillation will be long-term, and antiplatelets for ischemic strokes that aren't from atrial fibrillation, so all the ones from, say, atherosclerosis in the arteries of the brain, we use aspirin or clopidogrel. If they've had a seizure because of the stroke, they may need an anti-epileptic medication, such as phenytoin. Right? Phenytoin is a very common anti-seizure medication. Remember, phenytoin can cause gum swelling. It can cause, the anti-seizure medications are notorious for causing bad rashes, such as Stevens-Johnson syndrome. Okay, so there's many anti-epileptic medications. And finally, there are procedures where they can actually go into the artery following a stroke and put a stent. Those are still in the developmental stage. They're definitely happening, but they just haven't been perfected yet. Okay, but they're definitely occurring. Okay, so let's just look at some interprofessional care for stroke patients. So which other specialties will be involved with the care of a patient with a stroke? And it's not that all of these services are always required, but some of them will be, depending on the patient. So neurology, well, patients had a stroke. So often a neurology team will be involved in the care of a patient with a stroke, right? Neurosurgery is sometimes involved, especially if there's been a hemorrhagic stroke and increased intracerebral pressure. Okay, because some hemorrhagic strokes are surgical. Okay, cardiology is often involved if the stroke has been embolic from, say, atrial fibrillation. So they may try and convert atrial fibrillation back to normal sinus rhythm. The patient often needs anticoagulation if they remain in atrial fibrillation. Okay. Speech therapy, because speech, unfortunately, is often involved with a stroke. Physical therapy to maintain range of motion of joints, to help mobilize, to assess for whether the patient needs a cane or a walker. So all kinds of physical therapy treatments, including maintaining muscle strength, right? Otherwise, the patient is left with contractures of the affected side. They may, so physical therapy is really just to maintain muscle strength, mobility, and range of motion of joints. Occupational therapy, for sure. They're involved in doing home assessments, putting bars in where they're required, for example, in the bathtub, in the shower, down the hallways, assessing the house for safety. Are there carpets that the patient may slip on or get their foot caught on? So occupational therapy is often involved. Social services, because people often need some financial help. They need help with obtaining assistive devices. Okay. Laboratory services, because some patients need ongoing blood work. Someone who's on warfarin, for example, needs regular INRs. Okay, so laboratory services may be involved as well. So it's really a big team effort with various different specialties involved in the care of someone with a stroke. So patient education and family education following a stroke. And this really begins as soon as possible, right, with the family involvement. And often we get a good idea of how involved the family wants to be. Some families are really involved in the care of a patient with a stroke. Other families leave it more in the hands of different services. So it just depends on the different families. Okay. Once we have a good idea of how much the patient is going to recover, sometimes initially we have no idea, right? There's often some degree of return of function, but we really don't know at the onset of a stroke. But as the weeks go by, it declares itself how much neurological loss they have. So this often needs to be explained to the patient, needs to be explained to the family how much care they're going to need going forward. Okay, and that requires ongoing communication, of course. Now, the patient may go to a rehab hospital following a stroke. They may not go directly from hospital to like acute care hospital to home. They may go to rehab for a few months for intensive physiotherapy, occupational therapy, and then finally they need to adjust back to their home environment if they're able to go home. Okay. Okay, so let's do the questions at the end of chapter 15, and there's 5 questions. So this is on strokes. A nurse is caring for a client who has experienced a right hemispheric stroke. Okay, the nurse should expect the client to have difficulty with which of the following? So impulse control can definitely occur with a right hemispheric stroke. Okay, moving the left side of the body, absolutely. So right hemispheric stroke will affect the control and the movement of the left side of the body. So that one's true. Depth perception. So depth perception is a right hemispheric function. So that one would be correct as well. Speaking. So speaking and language are typically a left hemispheric function. Remember, so you have 2 areas in the left hemisphere. There's an area that allows you to understand the spoken language. Okay, so you understand what someone is saying. And there's another area in the left hemisphere that allows you to form words and speak the language. Okay, so that's the motor area that allows you to produce speech in the brain, put together words and sentences. And there's a sensory part in the left part of the brain, okay, that allows you to understand language. So it's not a right hemispheric function. So D would be incorrect. E, situational awareness. Yes. So your right hemisphere allows you to know where you are in space, right? You know exactly where your feet are, you know exactly where your arms are, and you know where you are in your surroundings. So the answer would be A, B, C, and E. 2. A nurse is caring for a client who has a left homonymous heminopsia. Which of the following is an appropriate nursing action? Okay. So homonymous heminopsia is where you've lost the visual fields in both eyes. So you have an optic nerve that comes from your left eye, and you have an optic nerve that comes from your right eye. And the fibers meet at the optic chiasm, and the fibers from your left visual field will cross over and go to, you should look at an image of this. This is going to be really hard to explain as an audio. So the fibers will cross, some will go to the left hemisphere and some will go to the right hemisphere. Okay, so let's look at the answers here. Teach the client to scan. So we're talking about a left heminopsia. Teach the client to scan to the right to see objects on the right side of the body. So somebody who has a left heminopsia has loss of their left visual fields of both eyes. Okay, so they can see objects on the right side. Place the bedside table on the right side of the bed. Well, that makes sense because their left visual fields are absent. They don't see them. So if you want to put something that they can see, you have to move it to the right side. Orient the client to the food on the plate using the clock method. That's not really necessary, okay? Because they can only see half of their visual fields, okay? And D, place the wheelchair on the client's left side. No, if you place it on the left side, they won't be able to see it, okay? I would suggest that for this, you look at how visual fields occur in an image. Just look up homonymous hemianopsia, and you'll see that at the optic chiasm, you get a split of the nerves from each optic nerve from the eyeball, and some of them go to the left hemisphere and some of them go to the right hemisphere. Okay, and if you have a stroke in the hemisphere and you've knocked out those optic nerve fibers, you're going to develop what's called a homonymous hemianopsia, meaning in both eyes you've lost either your left visual field or your right visual field. I'm not going to explain that on the computer because it'll be really, really difficult, and an image would help more. Okay. All right. So the answer there is B. Number 3, a nurse is planning care for a client who has dysphagia and a new dietary prescription. Which of the following should the nurse include in the plan of care? Okay, so dysphagia and a new dietary prescription. So have suction equipment available for use. Absolutely. So someone following a stroke and has, or just has dysphagia, you should always have suction ready in case they choke on the food, right? Feed the client thickened liquids. Well, if they have dysphagia, they're at risk for aspiration. So thickening water, so anything thicker than water is going to reduce the risk of aspiration. C, place food on the unaffected side of the client's mouth. Yes, okay, they have motor function on that side still compared to the paralyzed side, so it'll prevent the potential for aspiration. Okay, they have better control of moving the food. D, assign an assistive personnel to feed the client slowly. No, that wouldn't really be something that you delegate to someone else, just because of the risk of aspiration. E, teach the client to swallow with the neck flexed. Yes, that can help with the swallowing. Okay, so it helps with how the flap in the neck, the epiglottis, closes while they're swallowing, and it reduces aspiration. So the answer is A, B, C, and E. Okay. Number 4, nurse is caring for a client who has global aphasia. Okay, so this is what I was referring to before. So receptive means they don't understand anything that you're saying to them because the stroke has damaged the sensory, they cannot understand the spoken word anymore. So that's called sensory aphasia or receptive aphasia. And they have expressive aphasia, where they can't speak anymore because they can't put the words together in their brain because that part of the brain has been damaged by the stroke. Okay, so sensory, they don't understand. Expressive, they can't express the language. They can't speak. It comes out all garbled and the sentences are all broken up and words are fitted in that don't make any sense. Okay. Which of the following should the nurse include in the client's plan of care? Speak to the client at a slower rate. Okay, that's a good idea if they have a sensory aphasia. Okay, so they may be able to understand it if you speak a bit slower. Assist the client to use cards with pictures. Absolutely, that can help because these patients can become extremely frustrated because they can't, they want to get the words out. They want to put words together, but they can't. Okay, so B would be the answer. Speak to the client in a loud voice. No, they're not deaf. That's not the problem. So speaking really loud isn't going to help. Complete sentences that the client cannot finish. Absolutely not. That's just going to increase frustration, right? So don't finish sentences off for patients with this. E, give instructions one step at a time. Very good idea, right? So giving instructions clearly with each step fully explained, because they're having a difficulty understanding what you're saying, and also they're having difficulty communicating back to you. They have sensory and expressive issues. Okay, so the answer is A, B, and E. Number 5, a nurse is assessing a client. Which of the following findings indicates that the client has experienced a left hemispheric stroke? Impulse control difficulty? No, that's usually the right side of the brain, the right hemisphere. Poor judgment? That's more of a right-sided function as well, judgment. Okay. C, inability to recognize familiar objects. Absolutely. Okay, so this is called agnosia, and with a left hemispheric stroke, they can definitely develop agnosia, the inability to recognize common objects. D, lack of depth perception. No, depth perception is a right hemispheric function. Okay, that's it.